For 200 years, the work of Black journalists has been crucial to the lives of Black people in America. But the model for independent reporting is in decline, and disinformation prevails, targeted at Black communities. So we did something about it. We created a nonprofit network of local newsrooms anchored by a national hub, a different kind of news model for Black audiences, too often left behind, with stories too often untold. With our sustainable business model designed for the current market, we listen to and partner with the communities we serve to produce journalism that will expose injustice, inform policy, hold leaders to account, and equip Black audiences with the truth. Truth we deserve, news we need. Hi, everyone. I'm Akoto Foriata, co-founder and chief audience officer here at Capital B. Thank you so much for joining us today for this important event, the state of Black maternal health. The health disparities between white and Black Americans are particularly stark when it comes to reproductive and maternal health, with Black women significantly more likely to die as a result of pregnancy and birth than their white counterparts. Today, we'll talk to experts who are attempting to shed light on these horrific disparities and those working to find life-saving solutions. We're so grateful that you've joined us here to learn more about this critical issue. As always, the best way to support Capital B in this type of journalism is to become a member. You can do that by heading to our website, capitalbnews.org, and clicking on Become a Member. Thank you, and again, please enjoy the program.
Thank you for the welcome, Akoto. I'm excited to jump into the conversation today. My name is Margot Snipe. I'm the national health reporter here at Capital B News. And our first conversation of the day, I'm joined by three women who have done a lot of work in the maternal health space. Stacey Stewart, president and CEO of March of Dimes, Congresswoman Alma Adams, founder and co-chair of the Black Maternal Health Caucus, and Tanya Lewis-Lee, producer and director of Aftershock, an award-winning documentary on the US maternal health crisis. Thank you guys so much for joining me today. I'm excited to jump in. Stacey, a fellow Georgetown alum, Hoya Saxa, can I kick it off with you? I want to set the scene for our conversation today on this panel, but also the broader conversation we'll be having with a lot of different people who are working in this space. Can you talk to us a little bit about the gaps in cares and outcomes that we see between Black and white women and babies, and also why you think the disparities are so persistent?
Yeah, no, it's a great question, Margot. Fellow Hoya, great to be with you, and always great to be with the Congresswoman and our National Board of Trustees member, Tanya Lewis-Lee, on this conversation. So I'll just start at the highest level, because I think a lot of people are actually still becoming more aware that we had this maternal and infant health crisis that really preceded the pandemic and really has only been made worse as a result of COVID-19. But we were already in a pretty dire situation with respect to the health of moms and babies, even prior to 2020. And a lot of it has to do with the fact that we have so many gaps in care, in coverage, in high quality treatment that can go to deal with chronic health conditions for all women from all walks of life, irrespective of race, ethnicity, where you live, income level. You know, unfortunately, in this country, we are considered the most dangerous developed nation in the world in which to give birth. And that's especially true for Black and brown women in this country, Black women, Indigenous women, Hispanic women, and others. The reality is we aren't doing that well for white women either, unfortunately, but it's especially dire for Black women and other women of color. And a lot of it has to do with the fact that let me just start from the bare facts that, you know, we are a country, unlike other highly industrialized countries, that we don't have universal care, universal health coverage. We don't have the ability for every single woman to walk into a doctor's office to know that she can pay for coverage. We've had those gaps in care, but for the Affordable Care Act, we'd still have many millions of people without coverage. Thankfully, because of the Affordable Care Act, we've expanded that coverage. Not every state has expanded Medicaid coverage, but we've certainly expanded care for some. But it really goes beyond that, because most of our health and wellness is really determined not by what happens in the doctor's office. It happens by the way in which we live. And so a lot of our conversations and thinking around maternal and infant health really has to do with not just can we pay for coverage, and do we live in a county that's not a maternity care desert, right? That actually has access to an OBGYN, a hospital, a certified nurse midwife, or a birthing center. But it actually goes to these deeper issues in community about how we live. And to the extent that we still have too many women of color, Black and Indigenous women and other women who live in communities without access to adequate, safe, decent, affordable housing, without access to good nutrition, where we're paid inadequately for the work that we do. All of those kinds of social determinants that really impact if we're able to live a less stressful life, a life that is fully productive, then we are probably going to get poor outcomes. And that certainly is what we're seeing in a lot of Black and brown communities, where Black women are 3 times more likely to die as a result of pregnancy and childbirth complications. Not just on the mortality side is there an issue, but on the morbidity side, women that become severely ill as a result of pregnancy and childbirth. We are still struggling and have seen increasing rates of maternal mortality and morbidity in this country. And again, through the pandemic, that's only been made worse. In 1 year alone, we saw the increase in maternal mortality rates increase by 18%, and significantly so for Black and brown women. So we've got coverage issues, we've got care issues, we have the issues and the effects of racism and discrimination in this country, and then we just have a situation in which we basically allowed too many women, millions of women, in fact, to have the inability to really access the kind of care that they need and manage their health before, during, and after pregnancy. And so when we have that kind of situation, we shouldn't be shocked that we then see the kinds of outcomes we see with respect to maternal health, and even how that impacts our babies, whether or not they're born prematurely or whether or not they can even survive until their first birthday.
Yeah, like you mentioned, the disparities have persisted and may in fact be getting worse when you add COVID into the picture. I'm curious, Congresswoman Adams, what needs to change from a legislative perspective to achieve equitable outcomes?
Well, thank you, Stacey. Great recap. The maternal health and Black maternal health it's been declining, and so the gap in care has been getting wider. But in general, we have had an improvement in terms of awareness. This week is the 5th anniversary of the Black Maternal Health Week resolution, and last month was the 2nd anniversary of the Black Maternal Health Omnibus, and that's when the first Omnibus bill was signed into law. So, the policymakers do, I think, understand the problem, and people do now. We've developed solutions, and in some places like California, we've passed Omnibus legislation to address the Black maternal health at the state level, and a champion of Black maternal health, of course, our Vice President Kamala Harris, is in the White House. We've had some things to get worse, and COVID has been mentioned, that, when we first started looking at the problem, we didn't have a global pandemic. The pandemic didn't move the needle on policy significantly. So we don't yet have any universal health care for moms and children like they do in other countries, with lower mortality and morbidity rates for birthing parents. So, we do need to make sure that access is available to all of the women. Now, the Congresswoman Underwood and then Senator Kamala Harris and I introduced the Black Maternal Health Omnibus Act. Actually, it's been 2 years ago now, because we're really at a state of crisis in this country as it relates to maternal health. And of course, during that same week, we introduced the Omnibus. I think it's a great name. I think, what we're doing with that is just really outstanding. So the country went into lockdown immediately after that because of COVID-19. So we've had to do a lot of work to keep the conversation going. And I'm just happy to be a part of this conversation today, because it is so important that we continue to not only talk about it, but to raise awareness to the level that we can really see some substantive action.
Yeah. And I think some of these systemic issues that we've already touched on are part of what your film addresses, Tanya. Talk to us about the documentary. What does it highlight and what pushed you to make it?
Yeah, well, what pushed me to make the film was that back in 2007, I began as a spokesperson for an infant mortality awareness raising campaign out of the U.S. Department of Health and Human Services Office of Minority Health. And during that time, I had the opportunity to travel the country. I worked with them for 10 years, and I traveled the country, went to all kinds of regions, north, south, east, west, urban, rural, and had the opportunity to talk to women, to talk to people who were stakeholders in women's health, and just found myself immersed in women's health. And inevitably, I would talk to groups of women, and someone would raise their hand and tell me a story about a woman, a friend, a sister, a cousin, someone who had passed away from childbirth complications. And so, you know, over the years, I've been thinking about how to get into doing a film. I did a film about the infant mortality crisis, and I wanted to tell the story because I do think it is important that we tell these stories so that we raise awareness. The film, in my mind, is a conversation starter. It's a way that we can bring people together to talk about the issues and how we're going to solve this issue. Our approach to the film was to tell the film through people's lived experience, because I believe that's how you change hearts and minds, right? So we followed two families who had suffered the loss of a woman after she had given birth, or while she was giving birth. And you know, while they were going through their grief, they all were very activated as well to make change. They did not want their loved one to die in vain. And so we really tell the story through their eyes, through their loss, and through the world that they're walking through to make change. At the same time, it was really important for us to balance it with the information. So we do have a doctor and we do have a midwife who come and give us a lot of information, context to how we got here, and ways in which we can fix this crisis, because I am one to say there are many things in our world that we cannot change or fix. But the maternal health issue in the United States is not one of those. I really believe that when we all get on the same page, we can, and maybe even in my lifetime, we can change and turn this bus around and make it so that our outcomes are better for our children. Because my daughter, who is 27 years old, has a higher chance of dying from childbirth complications than I did when I birthed her, which is a disgrace. And it is my hope that certainly by the time her child is ready to give birth, that we've made for better outcomes. And the only other thing I'll say, you asked sort of what I sort of discovered here is that, and I think Stacey and Congresswoman Adams spoke to this very well as well, that we do in the United States have a serious problem of care coverage for every woman, but that's not just the problem, right? Because what we see in the statistics is that even women with access, even women who can get care, are not getting the best care, and they're still dying at higher rates than white women who don't have access to the care. So it really is a racial issue. And I would say that part of the problem is that in this country, we treat pregnancy as if it's a healthcare challenge to manage, not a real process that women just go through. We're also the only country, the only industrialized country that does not have midwives integrated into women's healthcare. And I really believe that has a serious impact as well.
Yeah, you mentioned just the stunning amount of women who spoke up to you about experiences their friends and family had when you first started. And that's something I've definitely found just in my reporting. The amount of times I picked up the phone and someone knows someone or is connected to another woman who has really been impacted by the healthcare system in their pregnancy, it's pretty stunning. And I'm wondering, I guess following up to that, was there anything, I guess, what did you go into the documentary expecting to find? But throughout the process, did anything come up that you hadn't expected? Did anything surprise you or reveal itself?
You know, I think Going into the film, I expected to see that, yes, there was implicit bias and there was racism in our healthcare system, which is impacting women. One of the things that's really striking to me is that it's not implicit bias, it is very explicit. I mean, so many people I've spoken to have told me just the way they've been treated has been very explicit. So I think the language these days, we talk about, oh, it's implicit bias. It's not implicit. People say very racist things and treat people in very racist, overtly racist ways. On the other hand, I will say that I think that there are people who are trying to do good things that sometimes cause problems as well, right? Well-meaning. So sometimes, doctors, are sometimes the care is too much too soon or too little too late, right? Like sometimes we don't allow women to progress in their labor. So we give them all of this medication and things don't work out well. And then we've got to rush in and do a C-section. But the thing that I have discovered is that doctors do want to figure out how women can get the support they need. Because I think ultimately that's what I've come to, is that each woman, whether she gives birth in a hospital, in a birthing center, at home by her choice, I think that we as women need to think about that a little differently in the way we have in the past. I never would have thought that. I gave birth in a hospital. It never occurred to me to have a midwife, much less go to a birthing center. But there are options out there for women. And I think it's about finding the right option for you. And really getting the support that you need, because when it comes to birth for women, it should be a women-centered situation. The woman who's giving birth needs to figure out who her support is and be well supported so she can have the birth that she really deserves and wants. And then we have better outcomes when a woman is able to be supported in that way and have the birth that she is looking for.
Yeah. With this in mind, Stacey, do you have other thoughts or additional thoughts on how we move the needle towards equitable outcomes? Like, where do we go from here? I think something that's been interesting for me is maternal health is an issue it's been reported on a lot. There's a lot of good journalism about it. We're talking about it in different spaces, but the disparities are really, really persistent. Where do we go from here? Where do we need to move the needle?
Yeah. Well, I just want to shout out Congresswoman Adams and Congresswoman Underwood and the entire Black Maternal Health Caucus, because we firmly believe that at March Dimes that, this is not, there's no one silver bullet solution to this. This is a very complex problem. I agree with Tanya. It is completely solvable, improvable for sure, and it just takes the will of lawmakers and the public and a lot of folks within our health sector and other parts of community to work together to solve it. Omnibus is, though, a package of legislative actions that begins to look at some core issues that actually do need to be improved upon. One is data collection. I mean, it wasn't until I had the opportunity to testify at the end of 2018 for the Preventing Maternal Deaths Act, which was legislation that actually gave more support to states to begin maternal mortality review committees. Before we had maternal mortality review committees, we were doing an even poorer job of collecting data on some of these issues to really understand the underlying causes of maternal mortality so that we could design better interventions. We are well on that way, but Omnibus actually goes further to help support better data collection. We need to do things like diversifying the perinatal workforce. Tanya's point on the fact that we are the only, industrialized country that does not integrate midwifery care into overall care for women is appalling. And it's that kind of care that puts the woman in the center of her pregnancy and childbirthing experience that will allow us to improve some of these outcomes. But we don't allow that kind of care to be scaled. It's not widely available in terms of Medicaid reimbursement, whether it's midwifery care or doula care. And there are just so many issues that Omnibus tries to cover in the broad span of the 12 legislative bills that are a part of it. And that will go a long way. And in fact, what was proposed is to have, as a part of Build Back Better, $1 billion investment to go along with those legislative actions. So we would firmly support policy change and investment in changing the practices and the ways in which we support women through their pregnancy and childbirthing experiences. But I think the other thing is that there still are a lot of areas that we don't really understand a lot of the underlying causes of some of these issues, or that we need to do more research to actually better understand some of these issues. So for example, we know that about one of the leading causes of maternal mortality has to do with heart-related issues, right? And that's especially true for women of color. That's especially true for women who are experiencing hypertension even before pregnancy, and then have issues around preeclampsia and other things throughout pregnancy. At the March of Dimes, we have prematurity research centers, and we're putting even more of our money behind maternal health research, especially around equity, to really understand the disparities. For example, our work with Stanford University, where we have a prematurity research center, we just published a paper that will lead us to hopefully the first test that will allow for early detection of preeclampsia at 16 weeks of pregnancy. That will help a lot of early detection and intervention so that preeclampsia and those kinds of symptoms and outcomes can be better managed, hopefully producing better results. We also need to do a better job. And I think, yes, it is implicit bias, it's explicit bias, but it's retraining our healthcare providers and training those that are currently in school today on how to provide the best quality care to every woman, every single woman who they treat. And that certainly has not been true. We've had many women of color who've said that they've experienced, outwardly racist experiences in dealing with their healthcare professionals. So at the March of Dimes, we actually started a whole training of healthcare providers, nurses, doctors, but not only them, front desk receptionists who often meet a patient walking into a clinic, and if they show a Medicaid card, all of a sudden take a different approach to that woman just based on her ability to pay, right? Those are the kinds of things that really diminish a woman's ability to seek care, to receive high quality care. So our training around this kind of bias, and we've trained over the past year and a half or 2 years, 35,000 healthcare professionals. We're launching now what we call a student bundle, so we can reach deeper into medical schools and nursing schools and any kind of training program for healthcare professionals to train people how to recognize their bias, because we all have some kind of bias against something. We're human beings, we're kind of wired that way. But what we're saying is that we've got to deconstruct the wiring that causes a healthcare professional to interact with a woman of color, especially, and treat her differently in ways that diminish her ability to receive the highest quality care. So having trained 35,000 on the path to training 50,000 healthcare professionals, we hope, and then even more over time, we hope will be one of the ways in which we can, address this issue and make sure that every woman feels that she has the support she needs and the care she needs to have the healthiest pregnancy and childbirth possible.
Wow.
Yeah, this is really interesting to me because actually just this week, the Pew Research Institute published a new study about views in the healthcare systems and medicine and science more broadly. But one of the findings within that was that younger Black women are more likely to report negative experiences with routine healthcare, and also more likely than other Black adults to say they'd prefer to see a Black healthcare provider for routine care, which I thought is an interesting piece of the discussion now. When you mentioned how the healthcare system interacts with young mothers and what that looks like. And I'm kind of curious, all of your perspectives on, for the Black women and families watching, what should they know as they enter pregnancy? Are there tips and tricks that you guys have heard along the way or in the work and research and advocacy you guys are doing that would help some of these families and moms navigate the health system?
It's been 50 years almost since I had my first child. But I have grandchildren and so forth. But I just think too often we just don't speak up. We don't ask enough questions. And I think you're talking about the younger generation. I think they do. And even sometimes I think these professionals tend to feel like, well, you're challenging them. I mean, but you know your body. And I think, we've got to do more self-advocacy, I think, as women, and help our women understand that you can, if it doesn't feel right, it's probably not right. And you need to continue to speak up. But, oftentimes, and you're right, in terms of the bias, sometimes we just don't know what we don't know. And that's why it's so important to not only advocate for this training, and that's why Omnibus is so important, because we have some provisions in that. It's a very comprehensive package that will address those, and that will also provide funding to community-based organizations that will work with women to help them understand the rights that they have. And Stacey's right when she says that it doesn't matter what kind of income you have, how extensive your coverage may be. I mean, you can look at folks like Serena Williams, Beyonce. I mean, clearly they have some of the best health insurance. My daughter had great health insurance. So I think it's really about helping to teach women how to be advocates as well for themselves, and then making sure that those who are serving moms or women who are pregnant, that they know not only who they're dealing with, but how you deal with everyone, and give the same kind of care to women, regardless of what their zip code is, regardless of how much health insurance they have, but understand that they all need effective health treatment. So.
Yeah, and I would just add, I agree wholeheartedly with the Congresswoman about our self-advocacy. And I would say in our film, we actually follow a woman who is pregnant. I think when we caught up with her, she was 35 weeks. And she had thought that she was going to give birth in a hospital with a doctor who she met. And over the course of us filming her, she decided to, with the help of her doula, look into a birthing center option for herself, and midwifery as an option. And so she did a lot of research to find another option for herself, and ends up having an amazing birth. And so what I would say is, along with that with that advocacy, is to start thinking a little bit differently. I mean, you asked the question, what needs to happen? We need a cultural shift. We need to start thinking about birth a little bit differently. It's not just about you go to your doctor tells you this and you do what the doctor says. It's about, let me take a step back. Let me educate myself as much as I possibly can on what birthing is and what's happening to me and what the options are out there for me. And if I go to a healthcare provider, whether it's a doctor or a midwife or a doula that I don't like, or I don't feel comfortable with, or is saying something that doesn't work for me, I'm the consumer. I'm not going to use that person. I'm going to find the right person that works for me, that makes me feel comfortable, that's really giving me the kind of care that I need. And along those lines, I would also say, because I want to be clear that I'm not just beating up on doctors either. I mean, I don't mean to beat up on anybody, but, I do think that people need to be careful as we're going out there looking for doulas, and as well, make sure you find the right ones too, because sometimes I have to say, I have seen situations where doulas do overstep and are not doing doula care, trying to do other things. So be a very smart consumer, know what you're looking for, and get the right people who are going to support you in your birthing experience.
And I would just add to that, Margot, that I think it's been covered pretty well. The challenge we have right now is that we have a situation in which women do need to advocate for themselves, and we want to enable them to do that well, right? But with the kind of education, at marchofdimes.org, we put tons of information out so that that's all been vetted, and it's helpful, and it's what you can trust, right? We don't want to deal in misinformation. We want to make sure that we're a trusted place you can go to for information. There are other places that you can go to at cdc.org and others to get information. What we want women to do is feel empowered to self-advocate. But what's been happening is that the onus feels like it's completely on them to advocate for themselves to a point where they may even have to advocate to save their lives, or their loved one may. And that's where the system has gone wrong, right? Which is that, we have folks like Charles Johnson, for example, or other spouses that were covered in Tanya's movie, Aftershock, who, were there to advocate for their loved one, and they still passed away. And so it's almost feels like you're powerless at the hands of a system that is not really respecting you and treating you in the way that you and your loved one deserve. And so what we're trying to do is combine the two things. One is self-advocacy through information, education, empowerment. You should ask questions of your physician or healthcare provider. You should not stop asking questions until you get the answers you need, right? And you should not no one should ever make you feel that you're not empowered or don't have a right to ask those questions. At the same time, we need a system to meet people where they are as well, which is, put the woman's voice at the center of the decisions that are made, not the institution's needs or desires, not any one individual healthcare provider's needs or desires. It's her body and it's her life. So she ought to be the ones to make, whose voice is the most listened to and respected. And that's unfortunately where the system has gone off the rails, really. And that's why we see some of the poor, very extraordinarily poor outcomes we are experiencing, especially for women of color.
And I just want to say, I love what Stacey just said. And I just want to add to that, I don't think women should be afraid to give birth. Please don't. These conversations should not put fear in women. You should be empowered. Do not be afraid. We want all of your beautiful Black and brown babies. So just be empowered and keep having those babies.
Right. And this should be the happiest time.
Exactly.
Absolutely. Absolutely.
And Tanya, you said something that I think really does hit home. And of course, I'm a lot older than you. I can look at you and see that. But the situation today is worse than it was 25 years ago, and even 50 years ago for me, when I had my son and then my daughter a few years after that. So that should not be. We should be improving. We shouldn't even be having this conversation because it should not be happening. And what we're talking about, it's preventable.
Exactly.
It's preventable. So but I appreciate all that you all have added. Thank you so much. But that just kind of struck me. I said, if it happened, if she feels that way, that things are worse now, and that your daughter will have a more difficult faces a more difficult challenge than you did.
It's insane.
Yeah.
We talked some about the systems and legislation and also what women and families can do. And I think we touched a little bit on what providers can do. I kind of want to talk a little bit more about that piece. If I'm sitting watching today and I'm going into the doctor's office to work tomorrow, what is something that I could implement for myself to maybe move the needle in a, patient to provider interaction?
I would just start with saying, come with all of your questions written down, take notes, bring a loved one with you. If you don't have a doula or someone with you, bring a spouse, a partner, a family member, bring your mom, a cousin, an aunt, or somebody, so that so that they can help you in that advocacy. And if you have a healthcare provider that's not comfortable with answering your questions, or if you feel like you're asking questions and not getting satisfactory answers to them, or you have questions about things that are being proposed or whatever, and you feel like you're being rushed into a situation, or you're rushed out of the office or whatever, that if you can't get those things resolved, then maybe it's time to look for another healthcare provider. In other words, the doctor you're going to, or the healthcare provider you're seeing, isn't the only one out there. So go pick somebody that you think understands you, is willing to work with you and listen to you. I certainly did that when I had my daughters, and have stayed close friends with my OBGYN for almost 20 years now. And that is the kind of relationship that everyone deserves to have with the person who's involved in what is supposed to be, as the Congresswoman said, the happiest time of your life. It ought to feel like a relationship with someone who is pouring the kind of love and care into you that you deserve. And, and this is especially true if you've got extenuating health circumstances. If you already know you've got some chronic health challenges, you know that you're going to need somebody who's going to take extra special care with you and kind of be there when you need. So again, it's just recognizing that at the moment of pregnancy and childbirth, you as the mom and delivering this newborn person into the world, there's nothing more special and sacred than that. There's nothing more loving and important than that. And a woman's not only physical health, but her mental health is really important at that moment in time. And we know that so many women, experience pregnancy as an extremely stressful time, and that's just not what it should be. And it's certainly something that needs to be managed for a lot of women, because we know that stress can actually cause worse outcomes. So we want to make sure that women are in a situation where they are feeling as supported as possible, and women knowing that they have the right to get that support is at the top of the list of important things that women ought to surround themselves with as they go through pregnancy and childbirth.
Margot, I heard that question a little differently. I heard it as as a provider. So I want to answer it what I would say to a provider, a healthcare provider in the room. I would say, I respect the fact that you've had many years of study and that you are an expert, but you are not an expert on that person's body. And so check yourself. When you come into the room, you don't come into the room as if you're the smartest person in the room and you know better than this person than they do about their body. Come into this room as an equal, understanding that you and this person now are going to embark on a journey together to get her to her best birth outcome. Do not think of yourself as above, but in concert with your patient, and that you are working with them to get them the best outcome. Don't think they're stupid just because they're not a doctor. Don't think they don't know, and that when they tell you they feel something, that don't brush it off. Listen to what they're saying. Listen when a woman tells you how she feels, and try to understand a little bit more about what may be going on in her life that may be causing some stress. Have a little more compassion, go out a limb and give a little more, maybe even in the compassion piece. I know healthcare providers are under a lot of stress themselves. It's tough being in that business. I know what I discovered is that healthcare providers feel very much like they go through a hazing process when they're going through med school and their residency. And sometimes that hazing gets passed on to patients. Be aware of that and try to course correct as you are interfacing with your patients.
Yeah, I would add, it's really all about trust. And you've got to build that level of trust. Very often, sometimes you go into a physician's office and not only do you not sometimes feel like you can trust that person, but you feel rushed. And so you want a professional who is going to take the time for you, the time that you need to ask those questions and so forth. And like you said, Tanya, there are lots of folks out here. So, you can get, what we say sometimes, go get a second opinion, go and talk to someone so that you can establish that relationship and that trust, because you're talking about investing 8-9 months. That's a long time. And I think when you mentioned the stress, and I do understand with the pandemic and all the other things that have been going on, certainly our healthcare professionals have been under an extraordinary amount of stress, but so have our patients. Women couldn't even get in to see their, it's just been, COVID has really sort of challenged us to the point of things lives just being not only torn apart, but turned upside down. And, it's fine. I appreciate the whole tele thing, the telehealth. I think that's been good. And it's been good when I don't want to go and get on the scale and let my doctor know I put on those pounds. She told me that's not to do. But you still, there's nothing like that one-to-one kind of conversation and contact. I call this the Hollywood squares, but I do think that trust is just so important. And, with all that women go through, that you've got to feel, like you've got the right person who understands, who has a certain amount of sympathy and empathy. Sometimes you just don't see that. I remember my mom lived till she was 90, and my doctor was my OB. He was from Jamaica, and we've been together for 30 years. He retired, and I took my mom there, and she said, I don't like him. He talks too fast, and so she wasn't comfortable. So I had to find, and of course, being that she was well up in her 80s and all. So, but I do think that really, you've got to establish that trust. And I think sometimes folks who are so busy, they've got patient after patient after patient, sometimes that's missed. And I think that when it's missed, then it's an even greater challenge for women who are giving birth. I've had a chance to meet Charles, and my bill is named for his wife, Kira, who never should have had the kind of crisis and to lose her life. That was just so unfortunate and unnecessary, and it's simply because the doctors overlooked, even the advocates in the room with her mom, her husband, her mother-in-law. They saw something going on, the catheter, blood, and the medical folks, they said they didn't think that was a priority, wasn't priority enough. And so then she passed away. So, hopefully we can spare the lives of so many women and so many children. I think about it now. My granddaughter, the youngest granddaughter, my daughter had that C-section, is 16. So that was 16 years ago when Janelle gave birth, and it just all of a sudden, and there were all kinds of problems, but they both survived. But think about so many people who don't, so many mothers, so many children who leave the hospital without their mothers, the mothers who leave the hospital without that baby. So.
Yeah, we're just about wrapped up on time. There's one thing you guys brought up that if I had to go over a couple of minutes, I really want to just give you guys space to talk about this, is we've talked so much about the disparities that some women are afraid to have children. And I know for me, having reported on the disparities, knowing what I know, having had these conversations, all that we've talked about today, I can tell you, I'm afraid of pregnancy and childbirth as a Black woman. I haven't had any kids myself, but I've spoken to other young women who feel the same way. There's got to be hope for us, though, and you guys alluded to some of it. Can you guys talk just for a little bit of time? I know we're a little bit over, but what are some of the joys of Black motherhood?
Wow. Well, all right. I'll go first. First of all, first of all, I think birthing and labor, is an amazing process if you are able to do it in the way that you want to do it. And, I've heard people say that when a woman births a child, she's also birthing herself as a mother, like a new person is emerging. And it's true. I mean, once you birth a child, you can do anything. You are so powerful. And so I would say that being a mother is amazing because you discover strength you didn't even know you had. And I'm not even talking now about birth and labor. I'm just talking through the process of mothering. You find that you have strength that you didn't know you had, that there is wisdom within you you didn't know you had, and the ability to sort of pour that knowledge that you have into this new person and guide them along the way as they come up is really just an amazing privilege and opportunity to do something good for the world and for yourself, because as a woman, you really do grow as a mother in ways that I know for me, I never would have had I not had children.
Mm. Thank you so much. That did give me some comfort. I've really appreciated this conversation, and we've just about wrapped up. Thank you all for kicking off today's event with me. Stick around for the rest of the programming.
Thanks, Margot.
Yeah.
Hi, everyone. I'm Kenya Hunter, and I'm the health reporter for Capital B Atlanta. I'm thrilled that you all joined us for this important conversation about undocumented immigrants and maternal health care. I'm joined today by Dr. Rachel Faby, a professor at SUNY Upstate, and Sadell O'Brien, an associate at Black Alliance for Just Immigration. Thank you so much to the both of us for joining us today.
Thank you for having me.
Thanks so much, Kenya.
Yeah, so I want to start with talking about setting the groundwork. What barriers and issues do undocumented people face when trying to seek maternal health care, in particular in the US? Like, are there any issues that are unique to Black immigrants?
Yeah, so undocumented women as a whole receive significantly less adequate care compared to citizens and other immigrant women in the United States. And this happens for a lot of reasons. Some of them are that there are perceived and actual risks of coming in contact with immigration officials. We know that Black women specifically are twice as likely to die from complications in childbirth. So when you add someone's immigration status to that, things that come into play are language barriers, the inability to explain their medical needs adequately. I've seen that firsthand, where sometimes there's a cultural barrier. They speak English, but they don't know how to properly explain their emotion in English. And then that leaves just this weird space in the room. And when you're really vulnerable and going through that time, it gets really, really difficult. And then other issues are just kind of socioeconomic issues. So the inability to pay for maternal health and the inability to take time off work. I know as an immigrant woman myself, and it can get really hard when you're thinking about going to work and making sure that everything's fine with the family and taking care of the family. A lot of women don't seek care because they cannot take off work because they cannot lose that.
Yeah, I think that really captures like the social and economic barriers that undocumented women face. But I think on top of that, there are also just policy barriers that make it harder for people to access care when they're pregnant and undocumented. So under federal law, undocumented people are not eligible for Medicaid. And in some states, the states have taken an option to provide care to undocumented pregnant people, but not every state has done that. So in a lot of states, you have to seek prenatal care and pregnancy care at a federally qualified health center where you'll pay out of pocket based on your income. So like Sadell said, if you don't have that income, you may not be able to afford prenatal care at all in these states.
And then lastly, just to add something else, I'm sorry. There's also the mental barriers that we think about. So family separation, that's a huge one. A lot of women are going through their pregnancy alone because they're separated from family, and it's hard to come to terms with exactly what is going on. So there's this need and this want to ignore what's happening, and a lot of women feel as if I ignore what's happening and it's not happening. So.
Thank you both so much for those answers. Sadell, I'm curious about what you've seen during your experience and your work at BAJI and working in communities. I'm curious about what you've seen and how being undocumented can kind of compound these really awful and dark statistics we hear about Black maternal health. And I know you kind of touched on that earlier.
Yeah. So I also work as a birth doula. So I've been in these rooms and it gets really hard. And one mom I'm thinking about specifically, she had the family separation that I just discussed. And she's been away from her husband for years. And she got to fly to see him finally after about 5 years. And on that trip, she became pregnant. And she came back, and her entire pregnancy was built around her trying to figure out how can she get her husband here to meet her child. And just the stress of what that looked like. So as her birth doula, I was navigating the immigration piece and then also navigating the maternal health piece, because I knew that she needed that. And it was nice to have me in a sense of, I understand the immigration system as someone who deals with family separation myself for the last 20 years. I know exactly what that feels like. I've never been pregnant, so I don't know exactly what she was going through, but we were able to connect on that level. So, and then in our communities, there's just this mistrust of the healthcare system. We know that racism plays a huge part in receiving adequate care. Like I said earlier, Black women are twice as more likely to die, and it's because they aren't being listened to. They aren't being trusted with their own bodies. So when we add all of that, the ground, it's ugly. If I'm being honest, it's really unfortunate. There's a lot of things happening. And I mean, the reason why I came into this field was because someone really close to me had a traumatic experience in childbirth. So I knew that there was a need. And then when I thought about my community, the Black immigrant community, I realized that the need was like 5 times more likely because, again, there's so many of us. Like, if you speak a tribal language, what does that look like? Can you honestly receive the adequate care that you need? You don't know what's going on. You don't know what decisions are being made on your behalf.
Dr. Favy, I'm really curious to know what you think when it comes to policy solutions. For example, here in Georgia, we just passed some legislation that would allow for prenatal care to be extended, or not prenatal care, but after your pregnancy, and so postnatal, where your insurance with Medicare would, or Medicaid would last for a year. But I'm curious about what other policy solutions you think would make sense in this space, especially as it comes to undocumented people, because we know that a lot of times in many states, undocumented people don't qualify for things like Medicaid. So what kinds of policy solutions do you think would make sense in a state like Georgia or anywhere else that doesn't extend these policies to undocumented people?
Yeah, I mean, I think the best solution is to extend it, right? And there are, I think, 19 states that use what's called the unborn child option, which is an option under CHIP that lets the state provide prenatal care to a pregnant undocumented person, essentially by treating the fetus as a beneficiary, right? So the pregnant person is covered while they're pregnant because their future child is receiving care. And so, that's not only happening in blue states. There are states across the country, Nebraska, Texas, that use this policy. And it lets, the pregnant person get coverage for their entire pregnancy. And in some states, it also extends 60 days postpartum, like you were talking about. Obviously, extending it for a year is way better, right? But it's a start. And then states like Maryland, for instance, are currently, as of very recently, they've passed a bill to implement this policy. It's actually sitting on the governor's desk. So hopefully that'll come to fruition for the state of Maryland too. And then in states like New York, where I'm based, instead of using this option, New York actually uses state-only money to cover prenatal care for undocumented people or anyone really, regardless of their immigration status. So, I mean, I guess my first answer to your question is just cover it, right? No matter what state you're in, it should be covered. Pregnancy is an incredibly delicate condition, right? You need all the care you can get while you're pregnant, and excluding people on the basis of their immigration status is just unjust.
That kind of, hearing that New York is one state that uses just, their state dollars. What role does the federal government play in this, I wonder?
Yeah, so on like federal Medicaid, for the most part, states no one can cover undocumented people, except for in cases of emergency. So labor and delivery are covered, but that care that you need before labor and delivery is excluded in most states unless they've taken this option. So, at the federal level, it would be awesome if they just removed that exclusion, right? But I think politically that's less likely to happen than having state action at this point, just given our current political situation.
And then, Sadell, coming back to you, I'm curious about what you've seen in hospitals as when it comes to undocumented people trying to give birth. I'm curious about what you've seen inside of the hospitals and what role you think hospital accountability would play in this. Because often as I talk with experts, I hear a lot about, yes, we have these solutions and these solutions, But ultimately, if the work isn't being done inside of the hospital or inside of, you know, the doctor's office to make sure that, I don't want to give your answer, but I'm curious on what you've seen as far as inside of hospitals or inside of, you know, just situations where people are trying to access prenatal care as a birth doula for undocumented people, and how you think that could compound, how you think that could extend on a systemic level.
So for me, this gets tricky. And the reason why this gets tricky is because my responsibility is my client, right? I take a person-centered, a family-centered approach. So it is about the family. I center the mother, the father, and the child. So navigating the healthcare system is very difficult. I'm also very passionate about it as a Black immigrant woman myself, because I know what that day-to-day is like without pregnancy. So it can be very difficult. However, when I think about what hospitals can do, I think the hospitals need to do a better job with doing outreach. And the reason why I say that is because one of the barriers that we see time and time and time again is the mistrust, right? Even if you're just a Black woman and you're not even thinking about your undocumented status, there's this mistrust with our healthcare system. And doctors and nurses and these hospitals need to do more outreach to let these women know, hey, we are here and we have your best interests at heart. If a hospital is located in an area where there is one type of immigrants in there, like, why not hire from that community so that you have that cultural support? Culture is really big for me, because there's a lot of women that come to America and their way of childbirth is different. It doesn't mean that their way of childbirth is wrong. They're just a part of a very different culture that does things in a very, very different way. And we need to be able to honor that. So when I think about hospitals, I just think that hospitals are not doing a good job as far as, like, I've seen doctors get really nasty. And we know that during childbirth, there's a part of your brain that kind of shuts down, right? Because of all of the things that your body is going through. So when a woman isn't able to think, a lot of doctors are taking advantage, and it's really unfortunate. And a lot of times they do believe that they're doing the right thing. It's not necessarily always mean-spirited. But when you're talking about a woman's body and a woman's right to choose what happens with her body, we need to be more aware of the decisions that we're making. We need to be more aware of the communities that we're serving, and we need to be better with it.
Dr. Fabi, I saw you kind of nodding along. Do you have anything to add?
Yeah, I mean, first I want to echo what Sidel said. I think that's all totally right. Hospitals could be partnering with doula programs and doing more outreach to communities. But another thing, you know, specifically in the undocumented space that's worth mentioning is something that we mentioned earlier is this chilling effect, right? That having fear of immigration enforcement, keeping people from seeking care earlier in their pregnancy, it results in worse outcomes, right? If you're afraid to seek care because you're afraid of immigration enforcement showing up at the hospital, that's going to harm your pregnancy. And so another thing that hospitals can do is implement some institutional policies to make people feel safer in their hospital settings. So there's one, I have a colleague, Altaf Sadi, who has done incredible work around evidence-based practices for hospitals and institutions that want to create safe spaces for undocumented patients. Her work is at doctorsforimmigrants.com. And there's just a set of evidence-based practices that include signage in your waiting room, or having a strict policy around where ICE, Immigration and Customs Enforcement, can or can't go within your hospital or within your health center, and having these policies in place and training your staff, you know, that this is a welcoming place. We support all of our patients regardless of their immigration status. That can go a long way to addressing that chilling effect that I mentioned. So that's another sort of set of steps that institutions can take.
Can we talk about some situations where someone might end up with what I read was called medical deportation? I know that we've touched a little bit on this as far as having a fear that ICE may show up, or that, you know, if you seek out care in an institution, you may end up getting deported. Can we talk about this, Dr. Fabi? And can you kind of explain to our audience what that means?
Yeah, so medical deportation is when essentially a hospital or a health center takes it upon themselves to deport a patient. It doesn't happen, I think, all that often. It's not the most common response that a hospital has, but it happens in cases where, for instance, if you have a patient who has been in a minimally conscious state on life support for months, who is undocumented, that costs the hospital a lot of money because, again, there's no federal support, right? They can't get Medicaid to support this patient. And so hospitals will essentially charter a private plane to send that person elsewhere. I don't think it is super common, especially now, but it was something that we heard a lot about in sort of the early 2010s. And it's a scary prospect. And I think rumors about that, about medical deportation being a thing, contribute to that chilling effect as well, right? Fear of ICE, fear that you're going to be sent home, fear that someone's going to find out that you are not authorized to be in this country and take it upon themselves to contact the authorities and get you kicked out of the country. It's a fear, and talking about it is important, but also, we don't want to scare anyone and make them think that this is a common thing too.
Right. And then, Sadell, I'm wondering how that can affect, something like that could affect maternal health, whether it's fear of treatment or things like that. Because as Dr. Fabi said, there can be rumors that come up, even though it's not that common. So how do you see it in serving your population as a doula? How do you see that affecting maternal health overall?
Yeah, it definitely affects the communities as well as the families. And I haven't really seen this a lot because fortunately I've always been able to talk people into getting healthcare, because once you have someone realize that their baby's lives is at stake, it typically drives their decision making. But there are women who are completely in fear, and what that does is the stress of being undocumented, as well as the stress, just the everyday life stress. It really does put children. So we always talk about Black women being 2 to 3 times more likely to die in childbirth due to complications. What we don't talk about is the statistics around the likelihood that a Black child will make it to 1 year old. And I don't have that exact stat right now, but the numbers has not been good. And so when we think about women not receiving care, or some of them are receiving care and aren't receiving adequate care, that's also a very huge issue, where they're telling the doctor, hey, something isn't wrong, something isn't right, something's going on. Like, I just feel like, but not being able to communicate that has a very, very negative effect on your baby. Whether it's the proper tests aren't being run. So something that could have been caught and could have been worked through is no longer being. It's too late by the time we realize it. Whether women are losing their babies and having stillborn babies, we've seen that. So the consequences are there. The consequences are definitely there, and unfortunately, they are happening. They are definitely happening. So when I think about the families, but then I also think about these communities, because these families are a part of communities. So not only are the families negatively impacted, but so are these communities.
Thank you so much both for your answers. One thing I'm curious about, I know we've touched on, just like Sadell did earlier in her answer, we touched on how Black women are more likely to die from childbirth than white women. But the other thing is that I believe that when it comes to undocumented women, that statistic is 10 times greater, or 5 times greater. I'm wondering, how you all have seen this statistic play out in your own lives, specifically you, Sadell. How have you seen how, whether it's language access or things like that, how have you kind of seen when it comes to, I'm sorry, I'm stumbling. How have you seen this statistic where undocumented people are more likely to suffer from bad health outcomes when it comes to maternal health? How have you seen that play out in your own work?
Yeah, so I typically see them ending in C-sections, which is really, really, really unfortunate. This one mom in particular I had, she she's from Africa. She's from a country in Africa, and we made it all the way to the end. She was able to dilate, and then she just had a really hard time pushing. And I think for that moment for her was, my husband can't be here. I'm surrounded by strangers. And her, like, she just could not connect her body and her mind in that moment. So I see that a lot. And she spoke English, but again, English was her second language. So when you think about her properly trying to explain herself and explain what's going on, and I could see the frustration, because at this moment she had been in labor. We'd been there for almost over a day, to the point where I had to tag another doula in. So if I was tired, I can only imagine just how tired she was. And she just wasn't able to continue on. And it ended in, we did have a healthy baby. And she did walk away healthy, but you think about how her undocumented status played a role in that. And that was a lot for her. That was a lot for her, and it was a lot on her family. And then, I mean, she was also a mom who literally worked up until she went into labor, because she couldn't afford to not show up to work. She had to deal with the stress of her job pretty much said, hey, we're not going to take you back after, like, if you're going to be gone for a while, you cannot be, you can only take a week off. She didn't have anyone to take care of the baby. So she was navigating all of these things while she was pregnant. And so a lot of times I see it result in C-sections. I've been fortunate enough where I have not seen it result in the death of a mother or a child. Mm-hmm. But it doesn't mean it's not happening, right? Being able to express yourself in childbirth is one of the most important things, and one of the things that I drive my clients to be able to do. And, you know, like we do a safe word, like, hey, if this is no longer what you want, like, you know, just to make it easier so that they don't have to really explain everything that's going on. It's just kind of like, I'm done without explanation. So when I've also been a volunteer doula for a lot of these women, right? Doulas are expensive. It's a privilege to have a doula. So when we think about it, and Rachel, you mentioned this earlier, hospitals should be partnering with doula organizations, and so that we can combat this.
Thank you so much, Sadell. Dr. Phoebe, I'm curious about what you see on the policy side when it comes to language access and childcare and childbirth. How does, and Sadell, I definitely want to hear from you on this too. How does language access affect the access that a mother will be able to have when it comes to childbirth? Because as Sadell talked about, expressing yourself during childbirth is key, but I imagine that if there's different languages happening and your caregiver can't provide that and doesn't speak your language, that could be a bit difficult.
Yeah, absolutely. Well, from like a policy perspective, you have a right to interpretation services. The problem is if you speak a language that, you know, within the hospital, they don't have an interpreter for, then maybe you're relying on a language line where like the interpreter's on an iPad and you're trying to, and in the middle of childbirth, I can't imagine that that's a particularly useful, you know, or effective way of communicating, right, is through an interpreter on an iPad or on a phone. And I've seen this, you know, I've heard stories from OBGYNs in the Rio Grande Valley and in California. For instance, a lot of undocumented immigrants coming from Central America and areas that just speak languages that are not Spanish, not French, not Chinese, not languages that people have interpretation services readily available. You know, the language line is the only option in some cases. Sadell, I'm not sure if that resonates with your experiences.
No, it absolutely does. And when we think about tribal women, right? The likelihood of a hospital having an interpreter for a tribal woman is very rare. It's extremely, extremely rare. So when you do add the iPad into it, it does get very, very difficult, right? You want to be able to just speak freely and not, you know, it's always like, get the iPad ready, there's just always this scramble. And going back to culture, when you think about, well, maybe in my tribe, this might be what it translates to, but it's not what I mean, right? So sometimes with tribal languages, we see that the translation isn't always perfect. There may be a word that just means something completely different culturally. There may be, and I see that with my culture, and I'm just Trinidadian, like, and I grew up knowing that, because my friends would be like, "Girl, what?" And so for me, I was able to navigate that because I've also been in the country long enough to know what someone means versus what my family mean. So we see that a lot, specifically with African women who are in need of healthcare. And going back to why I think hospitals should partner with these doula organizations, because if we're partnering with the community itself and we're bringing in women from that community, then we knock that barrier out. It no longer exists, So something that seems really simple, we just haven't caught on yet. So.
Well, my last question, and we've definitely touched on this as well. My last question for both of you is, what do you all want to see the healthcare system in the United States do better when it comes to undocumented people who are trying to have children?
Yeah, my answer is really simple. So I'll go first and knock it out. I think you just need to be providing Medicaid coverage. People need healthcare. They need to be able to pay for it. And so creating a Medicaid lookalike or using this chip option in every state. That's what I want to see.
Yeah, and I'm going to go more on the mental and emotional side of it. I really want to see the healthcare system care for people. Love goes a long way. And when you genuinely feel love from those around you, that goes a really long way in childbirth that I've seen. So I really want the healthcare system to do better with, whether it's just training their employees on cultural barriers, on the discrepancies, I want to see that in practice.
Well, I think we're going to stop there. Thank you so much to my two guests for joining us. And thank you to our audience for being part of this important conversation. And please keep following along. Thank you both so much.
Thank you.
Kenya.
Hi, everyone. I'm Shafali Luthra, the health reporter at the 19th, and I'm so excited to join Capital B today for this important conversation about maternal health in the Black community. In this conversation, we'll be talking about the inequities in postpartum care and outcomes and what can be done. And joining me are some of the smartest minds in this area. We have Jenny Joseph, the midwife and founder of Common Sense Birthing. We have Ms. Catherine Hall Trujillo, an MPH and the founder of the Birthing Project USA. And we have Dr. Didiamaka Amuta Onukaga, professor of Black Maternal Health and founder and director of the Mother Lab. Thank you all so much for joining me.
Thank you very much.
Thank you for having us.
I wanted to open this conversation just by getting a lay of the land of what's behind these persistent and really profound discrepancies between Black women and white women when it comes to both postpartum care and outcomes. Dr. Ayo, can we start with you?
Sure. Thank you for this opportunity. And I'm just so honored to be in such rich, beautiful company with Ms. Joseph and with Catherine Hall Trujillo. Thank you for having me. I think for me, when I look at the data, which I do all day, every day, just like the both of them, I think, the conversation would be remiss without framing it from a historical context. And so thinking about how Black and brown birthing people have been historically treated in the OBGYN reproductive health field, thinking about James Marion Sims and the work that he did on the bodies of enslaved Black women, Betsy, Lucy, and Anarcha. It was racist, it was painful, it was unnecessary. This is how we today are enjoying a speculum when a woman goes for an annual exam, or this is how we know how to do a fistula repair. These procedures were perfected on the bodies of enslaved Black women. And so that historical context of abuse and a systematic disregard by the healthcare system is still playing out today contemporarily when we see Black and brown birthing people at higher rates of maternal morbidity, maternal mortality. We know that 63% of maternal deaths are preventable, and that honestly, the healthcare system is so fragmented and so racist inherently in its nature that the needs, the priorities, the symptoms, the responsiveness to Black and brown birthing people is not where it needs to be. This is why we see people slipping through the cracks. When you hear statistics like 90% of maternal deaths due to hemorrhage are preventable, then you're wondering, how is it that 9 out of 10 people that die from hemorrhage are dying? In a country like the United States, in a country with the resources that we have, the technology, the excellent training of these clinicians, then that tells you there's more to the story than technology and medication and what we know to do clinically. There has to be something more. That's where racism plays out. You know, they call it implicit bias. I call it explicit racism. I can name the cases of so many friends and colleagues and people that we've seen who have died from preventable complications that should still be here today, raising their children. So that's what I would say, is that the discrepancies are based really in a historical context of racism in medicine and inherently how this healthcare system is set up to disregard and undermine the needs, priorities, symptoms, and resources that Black and brown birthing people need, but in a way that still plays out today. Now, I teach in the School of Medicine, and we know that if you ask the average medical student today, they're going to tell you that Black and brown people have higher pain thresholds, you know, are more likely to embellish their symptoms, and all these kind of microaggressions and racist tendencies play out in the way that care is delivered. So that's what I would say. Those things cumulatively contribute to the discrepancies and the inequities that we see playing out at the detriment of Black and brown birthing people. I'd love to hear from my colleagues, but that's where I'm coming from.
Wow, I mean, you said it all. I mean, seriously, what an important statement to open up this conversation, because if we don't look at it from that aspect with that lens, then we continue and perpetuate the fact that it exists and the fact that it's actually worsening. So I so appreciate that framing. Thank you.
I would add to it that our community has done a lot of, part of what's American culture is to acquiesce our care and our education to the so-called designated experts. And so that part of actually alleviating the problem is claiming back our power to actually know what's going on, to know what the expectations are of our providers, and to actually be really involved in what's going on, rather than giving up our power to people who don't have our best interests at heart.
Thinking about the postpartum period, right, which is such a vulnerable time for anyone who has given birth, what are the major risk factors that we see during this period, and what are the implications of these risk factors for Black women in particular? Ms. Catherine, why don't we start with you?
Well, actually, I would say that, and you know, everyone has their lane. Mm-hmm. And the lane that I'm most comfortable in is that lane of providing support to people. And whether that support is actually helping people figure out what the resources are that are available, how to use those resources, how to make those resources accountable. But that part of actually not being isolated and having to deal with whatever it is by yourself. So that would be the part, that's my lane. And I know my other colleagues, they're each in different lanes. When you put us together, we probably could do our best moonshot.
Well, I'm really glad that this topic specifically is centering postpartum, because for me, I'm a midwife. So my lane is in the care and support and education of normal childbearing people through the pregnancy, postpartum, but also the delivery. Well, for me, I've been in the United States 32 years, and I'm still horrified because there is no postpartum. Like, postpartum barely exists. What frustrates me more than anything about our care system as far as postpartum is that we have this little 2-day window that families are supposed to manage, learn everything, and be ready for, because after 2 days in a hospital environment, you're tossed out. You're on your own. You're put back into the community where there are really no resources for you. The most upsetting and egregious part about our outcomes, our maternal morbidity and mortality, are that the majority of them take place in the postpartum. How ridiculous is that? Like, we know where the problems lie, and yet our efforts are going towards, continually ignoring this space for people. We may now begin to talk about, oh, it's an entire postpartum year that needs to be addressed. And I'm thankful that we've at least started those conversations. But even with what we've agreed on as being postpartum, meaning up to the 6th week, 8th week postpartum, in terms of medical support or care, we really leave people bereft, because you have this window from 2 days, 3 days after being discharged from your care provider until 6 weeks postpartum, when some magical thing is supposed to happen. When you show up for your 6-week postpartum exam, at best you might get a pap smear, perhaps a pelvic exam, but no real help, support, or even care about what's going to happen going forward. So we instead then have a community of people in that postpartum timeframe who are literally lost, literally unsupported. If they do try to access resources, they're in a real no man's land. Insurance doesn't cover you in that space. There is no provider technically in that space. And you're left to your own devices. Hence, we have many people out there postpartally overwhelmed, depressed, perhaps even psychosis, as well as the fact that they are forced back into a workforce because we just don't want to do family leave and paternal and maternity leave for people as a human right. So there's all these other intersections that show up, but are so detrimental. And obviously the statistics point to that, because again, that's where most of our morbidity is showing up. And that's where I think we really are being remiss in supporting people, families, childbearing folk. They are left to figure it out on their own, and that's just plain wrong.
Well, I would add, in addition to all the richness that's already been said, I think, another way that we see these situations play out is really around, I just remember, so I'm 5 months postpartum. I have it's our second child, beautiful son. I have 2 beautiful sons. I have one that's 3 and one that's 5 months. And I just remember being, going through the pregnancy and just being asked these questions. And then immediately after he was born, it's like, oh, we got to get the baby to the pediatrician within 48 hours. I'm like, what about me? And I have a good relationship with my OB. She's a colleague and friend of mine, so I can text her. And, she did set up some nursing home visitation with a nurse and my postpartum doula, just to make sure I had that continuation of care. But that's frankly, I think, one, because I knew what to ask for, right? I do this work. 2, I have the agency and advocacy. These are colleagues and friends of mine. I'm in a place like Boston with a lot of rich hospital systems, and I know how to navigate myself in that world. That is not the case for most Black and brown birthing people who are really left to fend for themselves. Like Ms. Joseph has already said, it's really, really fragmented and scary, because that's where we're seeing a lot of the maternal death and the severe maternal morbidity. So I think we have to do a better job at this 4th trimester. This postpartum period is critical, particularly in the first, 2 weeks or so, just really monitoring the blood pressure. Every time I see a pregnant person, I'm always like, hey, do you have a home blood pressure cuff? Hey, how are you feeling? Do you have sensitivity? I'm just in a grocery store, right? Do you have sensitivity to light? Do you have a headache? I'm looking for some swelling. I'm not an MD, I'm a PhD, but I know what to look for. And so these are the questions that we as a community have to really be supportive and inclusive of our fellow birthing people, because the system is not going to meet us at our level of need. We have to rally and support each other, right? And with the richness that's in the room, the work of Ms. Joseph, the work of Ms. Catherine Hartrell-Hill, these are the resources and organizations, the work that I'm doing in Mother Lab through a research and advocacy perspective. These are the organizations that are moving the needle, right? It's really going to come from the community rather than expecting the healthcare system to be responsive in the way and in the magnitude that it needs to be.
I would also like to add something to this. Now that I am primarily working as an ambassador for FIRE, which is the Federation of International Gender and Human Rights, I'm acutely aware of how much the US operates in a vacuum and how different we are from every other country in the world. We actually do not have to reinvent the wheel. Like what Miss Jenny Joseph, and I have to say Miss Jenny Joseph, I love Miss Jenny Joseph, but what she is saying about, for example, we're the only developed country that does not have family leave. I'm based out of Cuba, which has mama leave, daddy leave, and grandparent leave. And grandparents are considered the first supporters of a family and get the support and the training and education they need to be able to start at the family level, to be the one that's eyeballing someone who has just had a baby and supporting them. And so the way that we're doing it also in the sense that we're looking at pregnancy in a vacuum, you know, as she also said, you know, we hone in for this time that you're pregnant and right after you have the baby, and then you're on your own. And so the idea of the way that we're developing it all by ourselves without looking at what the rest of the world is doing, I think is really a detriment to us, because we are behind every developed country in the world in the policies that drive the services that we get.
You know, I just want to piggyback on that real quick, because I really see we do have enough understanding of issues when we go overseas. We export all of the brilliance, the money, the contractors to go and fix and help and solve where maternal mortality, morbidity is rife. And we have really amazing solutions that work. Mm-hmm. We see the change, we see the improvement in the outcomes. We feel that we are making, some inroads in mitigating, especially in underdeveloped nations. So I, to the life of me, can't understand, why can't we take these models downtown? Like, how hard is that, given that we could actually do the exact same thing we're doing for developing countries and do what we know is absolutely a human right. It is from that aspect, from the social justice, from the reproductive justice, maternal and birth justice. It's justice work that is needed here. It's not, we don't need to improve our, well, we do actually need to improve our care of physiological issues. Obviously, it would be a good idea to stop, people dying from hemorrhage, yes. But these underlying issues are really these other levels that countries such as Cuba have already figured out and have deployed the workforce to manage it. A community-based, a community-level workforce, wherever we have shown up to help, has been the most effective way. Folk with the lived experience, folk with the ability to be culturally safe, culturally congruent, to, without extra work and effort, being able to have an affinity to elicit trust, because being respectful to their community peers and members is second nature. The most cheap and cost-effective way to train, deploy, and build out workforce, we all know what to do. It's like, it's so frustrating, but it's also so wrong on so many levels, because literally people are dying for the lack of us being willing to move in that direction.
Absolutely. As we're talking and I'm listening to both of you and all your knowledge and wisdom and expertise, I'm reflecting fondly on my two birthing experiences. So I'm Nigerian, and in our culture, I'm Igbo, that's my tribe. And in our culture, we have a ceremony called Omugwa. So anybody that's listening that's Igbo will know what Amugwa is. Amugwa is a rite of passage when a woman becomes a mother. So my mother comes and stays with me. She did it for both my kids. My mother comes and stays. First of all, my mother-in-law lives with us. So I have that in-house care, in-house support, right? Intergenerational household. My mother comes and stays with us for a period. If this was in Nigeria, maybe 3 months. So here in the States, I think she stayed 2 months the first time and then maybe 6 weeks the second time. In that 6, 8, 12 weeks, first of all, my mom is in the room with me as I'm birthing, right? She's making sure everything is moving. And I had a doula and I had my partner, right? So got the whole tribe, okay? Everybody is in position. And then, you know, she comes and she stays. There's certain like soups that she's cooking for me in that initial 24 to 48 hours, right? That have certain medicinal healing properties to get the uterus to stop contracting, to work towards producing breast milk, all these beautiful properties that we see going on, right? In the meantime, they're monitoring me, right? They're watching, hey, does she have a headache? Is she drinking enough water? Let's take the baby so she can go take a nap. Just all these things that happen just culturally, naturally. And, you know, I've had beautiful pregnancy and postpartum experiences because of that. That should be the standard of care. And you don't have to be Nigerian to enjoy that. But what I'm saying is the way that our system is set up, as we're talking about the United States and how we operate in such a silo and a vacuum, and we are so tone deaf to what's happening in other parts of the world. There's so many beautiful practices and beautiful things that are really beneficial to the family unit. And I love what you were saying, Ms. Trujillo, around, you know, the grandparents being the first ones to be trained.
Yes.
That's brilliant. Where are my kids now while I'm doing this interview? They're with their grandmother, right? She is, you know, part of the leadership team in this household. She's the one that keeps it running afloat. That is so important. There's so many cultural dynamics that we as a country should be picking up and capitalizing on that are so beautiful and happen so organically in other parts of the world. We are really, really missing the mark when it comes to those things. All of these things would have huge implications for reducing these rates of inequities and reducing unnecessary deaths and complications. It all plays in together.
I actually feel very encouraged and inspired because I see that you two are doing the thing that's most important in terms of stepping up and reclaiming the power.
Yes.
You know, redefining what education is, redefining what resources are. You know, we've been used to going on financial resources, but human resources are much more important than financial resources. But you are those generations that are stepping up. Yes. And making sure that things change. Because actually, if the United States had no Black people in it, it would still not be in the top 10 in terms of birth outcomes. That's so the right. Things that we're talking about changing for people who are most impacted, when they move up a little bit, everybody is going to move up a little bit. You know, the United States does not do well in any of those things except the military and money. We don't do well in education. We don't do well in any of those things that measure, you know, the quality of life in a country. And so I'm like, yeah, it's gonna be all right because they got this. You're not gonna be quiet anymore.
I do want to ask, and I think this question really goes to all three of you. I'm really interested in the question of like how, and is it possible for the government, either the federal or the state, right, to implement policies that could actually, right, address birth inequity and could engender some of the, like the change and betterment that you're all talking about? And it sounds like there are some things that we could see, right, from leadership. What do you think that is? What's most important?
Well, you know, I'm going to jump in here. There are things already in play and have been, right? But what we haven't got achieved here in the United States is an ability to take policy and transfer it into action, right? I mean, it looks good on paper, but oftentimes we're not getting any further. So we do have, for example, the Maternal Health Omnibus, which is part of the Black Maternal Health Caucus, which is focused specifically, I believe there are 12 bills where they are addressing needs of Black and Native American Indigenous people. And they are specific, looking at workforce development, looking at community-based providers, looking at midwives, doulas, community health workers, looking at the military moms, looking at technology, obviously looking at COVID. Each bill addresses issues that we know are very, they are imperative if we are going to see any changes in our outcomes for Black and other marginalized folk. Here's the problem. When we put these policies in place, we don't have any providers, or we're not willing to create the providers to carry this work forward. It is really strange when you think about it. The workforce is able to be developed, but we just keep choosing not to develop the workforce. We already have enough research that points out the impact and the value of doulas, community health workers, resource mothers, peer counselors. We don't have any need for any more research before we move ahead with let's get reimbursement for these people, fair and equitable reimbursement. We're talking about economic justice here for people who can be and are already on the ground providing work. I mean, the tremendous playbook that Mother Catherine has put out for us, it's been there. we followed it. We know, and she has proven that the community-based support changes outcomes without all of this unnecessary and extra expense and drama that has been created around addressing perinatal outcomes. So when we put policies in play, we just have to do the part two, which is fund, support, and sustain the community-based and community-led practices that can collaborate with the existing resources, and together we'll get to the other end. We'll get to those outcomes that we're looking for. Right now, we keep these silos, we keep the territorialism going, we keep the money in the places where it already exists and it's not making a difference, and we keep wringing our hands and saying we don't know what to do. We really do know what to do, we just choose not to.
We know what to do, and at the same time, you know, this is why this conference I'm having on Friday, it's the 5th annual Black Maternal Health Conference. I had the pleasure of having Ms. Jenny Joseph speak last year. She was amazing. Ms. Trujillo, I'd love to work with you in the future. We do a different theme every year. This year, the theme is on policy. And we are excited to speak with the CMS Administrator, Center for Medicare and Medicaid Services, Ms. Jaquita Brooks-Ashore. She's coming to do our opening remarks because we know that 60% of births in this country are to the Medicaid population. That's how you start to move the needle forward. We need champions in these large government agencies, right? The CMS and the HRSA and NIH, people that are really making these funding decisions, creating funding priorities through their strategic plan, through who's in office, through these leadership appointments, to be able to move some of this federal money out to the state level. And then when you get to the states, you need people that are gonna do stewardship with it, right? So this stewardship that we need of these resources, here in Massachusetts, I sit on the Racial Inequities and Maternal Health Commission. This commission is a 27-person body appointed by Governor Baker, approved by the House and the Senate here. We are tasked with creating a blueprint for the Commonwealth of Massachusetts. How do we move this work forward from a policy perspective? And then how do we get the funding from the governor? How do we get the funding from the federal legislation? So it's not that we don't know what to do. We have to put systems in place that have teeth, that have resources attached to them. I don't want to be in any more governing boards or coalitions or commissions just for the purposes of showing up in a room and eating good food and talking to people that already understand the problem. We are here to move the work forward. While we're here patting each other on the back with all our accolades, people are dying.
That's right.
While we're here patting each other on the back at these fancy meetings and doing keynotes, we're missing opportunities to save lives and to really interrupt how racism is showing up in the healthcare system. So that's, you know, you have to dismantle the system from within. You have, it's like the Trojan horse. You have to come in on a Trojan horse and then you get in and you dismantle the system. You can't dismantle it from the outside looking in. They need people that look like us in this room at the table in these places, holding these systems accountable. That's why we're doing the focus on policy this year, because political will, political changes, political resources are going to help move this work forward.
I would like to see, in addition to all of this, I would like to see us take maybe a position like the one we're taking on homelessness, where you have a model city and you address every single issue that's connected with it until you solve the problem and there are no people living in their cars on the street. I think Washington, D.C. would be a good place to start, right down the street from the Capitol, where the infant mortality rate is like a developing country, and focus because now when we do policy or we do funding or whatever, it's piecemeal. And whoever is successful enough to get funding gets a part of this and a part of that and a part of that. But I haven't seen anything where we address everything at the same time to get to the end so that we could see that. And then that would be a model. And I'm not saying we stop doing the other, but I think in addition to that, if we had one place where we did everything, because sometimes we don't know the little things that really, really make a difference. You know, you have all the pieces but one. And to prove that actually, if we did all this stuff, our mommies and babies and could actually have babies and they could live through the process.
Absolutely. That's beautiful. What you're proposing is a comprehensive response and not a piecemeal response. You know, I have the good fortune of being one of 6 principal investigators in the country to have an R1, which is a large multi-year grant from NIH focused on maternal health disparities. I'm sure I'm the youngest principal investigator of the 6. I'm sure I'm the only person of color of the 6. So it's a tremendous, you know, you have to jump through a hoop and stand on your head and run 3 times fast. And it's just ridiculous what you have to do to get funded. And then once you get the funding, you have all the bureaucracy and the red tape that goes along with it. While I'm here doing subcontracts and data use agreements, women are dying.
We never got, the Birthing Project never got federal funding. I was an expert reviewer, but part of it was just the pride of putting the things that were important before reviewers who didn't even know what you were talking about, or they said you didn't say it right or whatever. So just that stubbornness in me, but also because you would have to say ahead of time what was going to work, and having that kind of template that doesn't work for everything. And then you had to have a certain success rate in order to get funded again. So all of those things that really stand in the way of actually coming up with a comprehensive solution and the flexibility to do what needs to be done. I think we have one of those grants that you're talking about too at Charles Drew University in Los Angeles, right? And what they wanted to do was a maternity house. We are still trying to figure out how to do the concept of a maternity house, but it's stuck in the policy. Yeah. Like, who's going to take care of the kids while the mom is in the maternity house? You know, can you get off work to do that? You know, the bigger picture of what if we had a place where a woman who needed to be on bed rest could be on bed rest while her other 3 or 4 children could be taken care of.
Beautiful, beautiful. You have raised so many inequities. You know, I represent 2% of medical school faculty that are Black or African American. 3% of PIs of color that get this level of funding. It's really, really, the system is broken and it's rigged. And, you know, in those review committee meetings, I remember I sat on one, I left in tears. I'm like, who's ever going to get funded with this horrible process of just shredding all the research and the science, anything around community engaged work? It's horrible. And a lot of these funding agencies, NIH is not alone in that space. Like, a lot of them are starting to revamp their criteria, the way that they give out grants. They're starting to repopulate these review committees. I get a ton of requests to sit on study sections now because they understand the importance of that diverse experience in the room. So we're just now starting to turn that page, though, just now.
Yeah, but don't give up. And also educating people, like the people who are probably going to see this may not know that the local government, state government, and federal government is always should be looking for anyway, community expert reviewers.
Right.
You know, so everyone who's at least in graduate school should be making some money reviewing proposals, but who knows about that?
I know. Well, here's the thing.
But now they do.
Now they do. It's the old boys club. You're on a spreadsheet on someone's computer until they find you. It's really, the network has to be stronger, and we need people on the inside.
We're gonna do this.
Yeah. we are.
I know we're running low on time, but I did want to make sure before we get to the end, we had a chance to talk about mental health in particular, thinking about the failures, right, to detect and treat postpartum anxiety and depression for Black women in particular. What's behind these failures, and how should we think about them as part of this comprehensive solution that we've all been talking about?
Well, there's no structure, as I've mentioned already. We've talked about the fact that there's these gaping holes in the postpartum continuum of care. One of the difficulties that I find as a clinician is I screen very thoroughly and take a lot of time and energy to support postpartum mothers. And when you screen and they do score high on these depression screening tools, then we're stuck because there's no one who will take this particular Medicaid or that insurance plan, or there's a complete dearth of behavioral health providers, whether they're trained in postpartum or not, but that understand the importance of picking up where we are finishing up as clinical providers and continuing on with that support throughout that postpartum year. Even if somebody does get referred to somebody, it's sort of a short-term, quick thing, and they're like moved on. We need a continuum of care, a continuum of access. You've seen, like, during the COVID pandemic, there's so much more access on social media and information about mental health and getting a virtual appointment with a counselor. We haven't ever done that for women's health, and particularly not for postpartum health. But that's what's missing. I think it's simply a lack of resources and a lack of being able to make the referral and know that your client actually is going to land somewhere that is going to be able to continue that care and to be a steward of that responsibility. Because once they've had their baby, I'm just going to say it again, it's like the candy wrappers. I think it's Dr. Stewart who talks about the fact that you throw the candy wrapper away because the baby's out, and mother is like completely disregarded and has no access to these sorts of resources.
That was so well put. I know we are running up against almost the end of our time. Before we go, I just want to ask each of you maybe a two-part question. How do you think true birth equity looks in this country? And on what note, more broadly, do you want to end this conversation for our audience?
For me, I think true birth equity looks like, a better birthing experience for my children, my daughter-in-laws, my grandchildren. That's what it feels like for me, that the work I'm doing will be of benefit to the next generations. And it also looks like, the training of future maternal health scholars. The work that my research lab is doing, the Mother Lab, www.motherlab.org, the work that's coming out of that research lab, training the next generation of Black and Brown and white allies who are really focused on reducing maternal health inequities, that's what birth equity looks like to me. My students are going to go on to be OBGYNs, nurses, social workers, doctors, clinicians, researchers. So we're infiltrating the healthcare workforce from this lab. That's what birth equity looks like to me. It also looks like creating and holding space for community. So it looks like the work that's going to be happening in this center that I'm launching, the Center for Black Maternal Health and Reproductive Justice. I'll be reaching out to both of you to be affiliates with this center. It just got approved this week. But we're going to be launching this center, and the premise of it is community engaged work. So it'll be housed in an academic institution and a school of medicine, but the heart will be in the community. That's what birth equity work looks like to me. And finally, I would be remiss if I did not give a huge shout out to the Neighborhood Birth Center here in Boston. I'm on the board, and we are working to open our doors next year to create an out-of-hospital alternative for people to safely give birth. That's what birth equity looks like. I was on a call earlier today in our Slack channel, and we were sending out some renderings of the place we hope to purchase here in Boston, where real estate is really expensive, to create our birth equity, our birthing center. And I got chills. I'm like, I want to have my future kids in this place, right? We got to get these doors open. That's what birth equity looks like to me, creating space for birthing people to have the type of experience they want to have. Doesn't have to be in a hospital setting, doesn't have to be with a lot of intervention, doesn't have to be feeling rushed because a shift is changing and people want to go to dinner. That's not what birth equity looks like. Birth equity feels like it's born and it's really come out of the community. That's what it feels like to me. So I would be remiss if I didn't lift up the work of Neighborhood Birth Center, the work of my research lab, Mother Lab, and then this future Center for Black Maternal Health and Reproductive Justice. That's what it feels like to me, advocacy and doing it from the love. Thank you.
I'm a cat.
Well, I think the thing that breaks my heart around birth equity is that it has affected Black women to the point that women are saying, I'm afraid to have a baby. Yes. That breaks my heart. So I think that birth equity looks like creating a world where a woman is not afraid to get pregnant because she doesn't feel that that she is going to survive or the baby's going to survive. That's the world I want to create, where you don't have to be afraid to be pregnant and have a baby and raise a baby. And I think I would also be remiss to not remind us. I'm looking at two beautiful providers right now. And sometimes we say, we have no doctors, we have no this, we have no that. I think that what we need to do is actually acknowledge and lift up the people who are in the business, who are doing the business of creating birth equity. We have a lot of young professionals that no matter how they're getting trained in universities, old school way, they are actually bringing in that new school thought of, we're not going to do it that way anymore. And I think that if we encourage people to do that, that's going to be more the norm than encouraging them, not acknowledging and supporting them when they are doing something different, because that's how different becomes the norm. And I think I said earlier, looking at you all, if you were the norm, we would have birth equity. So it's about finding the good and really acknowledging that good and lifting that good up so that people will have the courage to do it no matter what. Then I think we'll also have birth equity.
Oh, wow. Well, I am encouraged and have been encouraged. Everything that I have tried to do was based on what I've learned from Mama Cat and the work of the Birthing Project. Yes, ma'am, there's no question. And one of the things that we have taken forward from that work and that thought process is that we are literally in the business of building a movement to birth a more just and loving world. Exactly. And so our organization, Common Sense Childbirth, we have the National Perinatal Task Force for that very reason. And our main work is about equity, perinatal quality, perinatal safety. And we are building that workforce to provide that for every community, every person, every time. So that's how we see equity. We are operationalizing and embedding perinatal equity back into our communities.
This has been such a wonderful conversation. I have learned so much. I have no doubt the audience has as well. Thank you so much for participating. I really enjoyed this.
Thank you so much. It was a pleasure.
Good afternoon. I'm Lauren Williams, CEO and co-founder of Capital B. I am so glad that you've joined us for today's event and for this important conversation on Black choice and reproductive care. Joining me is Alexis McGill-Johnson, President and CEO of Planned Parenthood Federation of America. Alexis, thank you so much for being here today.
Oh, it's great to be here, Lauren. Thank you for having me.
And so I thought we could just start off by setting the stage. Can you tell us how choice and reproductive rights factor into this broader question and conversation about Black maternal health?
Yeah, well, I mean, look, as you know, where we are with respect to whether or not we can access a right that we have enjoyed for over 49 years is one question, right? We have established a constitutional right to our choice, our ability to make decisions about our own bodies. And yet we know what our reproductive justice colleagues have told us, for so long, that just because you have a right in name only does not necessarily mean you have access to it. And so sometimes we use the word choice and really meaning to unpack that, right? Because not all choices are equal. If you don't actually have the ability, whether that is the ability to access it in state because of the number of providers or restrictions, or whether you have the resources to access your ability to connect. But what's really important here is the fact that the same states where we are seeing the significant restrictions around access to abortion are the same states that have the worst maternal health outcomes. They're the same states that have the worst voting rights restrictions and outcomes. And so as we think about kind of health and choice and rights and access, we have to look at kind of the ways in which, locally our ability to access any of them is limited by the ways in which our lawmakers are showing up.
Yeah, and the, like you say, the states where the rights are being curtailed are some of the states with the worst outcomes, but they're also some of the states with the largest Black populations, and in general, Black women get abortions at much higher rates than white women. But in some of the states in the South, the many more Black women are getting abortions, and so when they're banned or those rights are curtailed, that has this conversation has a specific salience when we're talking about Black women. So can you talk about what this moment means for Black women in particular?
Yeah, absolutely. Look, I mean, here's what we know, right? We are like 7-8 months into SB 8, a horrific 6-week ban against abortion in Texas. That not only impacts ability to access abortion after 6 weeks, it also encourages surveillance and the implementation of what we call a bounty hunting provision associated with it, so that if you are identified as helping someone get access to abortion in the state, you are able to get to secure a $10,000 bounty by telling on that person, right? So what we see in a state like Texas is, and many copycat bans across the country, is an effort not only to deny access to sexual and reproductive health care, after all, abortion is health care, but also the criminalization, right? The increased surveillance, the policing of the Black body, that is what we've been fighting for over 400 years, right? Our ability to make decisions about our own bodies, but it becomes particularly acute for Black women in our bodies. We also have the Supreme Court. We are waiting a decision in a case called Dobbs versus Jackson Women's Health, which is a 15-week ban in Mississippi. Again, another state that's predominantly Black, the one where the health outcomes generally are incredibly poor. Maternal health outcomes in particular are poor. Also, outcomes for children, right? In the state, outcomes for foster children in the state. And here you have a 15-week restriction that the Supreme Court has taken up the case. The way they took it up goes directly to the heart of Roe, right? As to who gets to make the decision pre-viability. And we know if the court, which it seems to do, lets that law stand, it will create a ripple effect, as we're starting to see with the number of restrictions being introduced across the country, that will expedite the end of Roe in 26 states. We're talking 36 million people who could be impacted by this law, people who could become pregnant. And at the center of that, Black women, right, who disproportionately bear the brunt of relentless attacks, not just on access to abortion, but bodily autonomy. And it looks like, what we see, right? People what we're seeing right now in Texas and other states, having to secure childcare, to secure resources, to secure days off from work, to travel out of state, to get access, thousands of miles to get access to basic health care that they should be able to get in state. And so, we always know that when other communities, have a cough, we have a full-on flu. And I think that's exactly what we are likely to see in this moment as we await the Supreme Court decision.
Mm-hmm. In Georgia, where Capital B has a newsroom in Atlanta, 65% of abortions of reported legal abortions are Black women. And Atlanta is sort of a hub across the region for abortion care. what would you sort of say to Black women, particularly living in these states where if Roe v. Wade is overturned, their rights are going to be immediately effectively erased? What do you say? What's the next step for women in need of abortions?
Well, first of all, if Roe is overturned, we won't go quite back to where we were pre-1973. There will still be 24 states where we expect access to abortion to maintain, right? But what people need is the ability to get access to those places. They will need access to abortion funds, funds that are resources where people can go to gain access to provide for the care, the transportation, again, the childcare, all the gas money, quite frankly, right, to get from Georgia to a North Carolina to a Virginia to a Maryland. That's what we are already seeing in coming out of Texas, right? That what people are being forced to do, they're either being forced into pregnancy or they're being forced into this extensive travel, and they need the support. The reality is that it will be hard to stem the tide of these restrictions and seeing these laws get implemented, particularly as they are flowing through the South. Because when we're looking at Texas and Georgia and Florida, those are really have been kind of gateways for access in many of the southern states. So we also have to think about what the long term is, right? We have to recognize the fact that getting people to travel state by state, flying people all across the country is actually not a future state. It means that we are going to have to think about what it means not only to get people to the care that they need, but also reconstruct the right. And as I mentioned before, this right is so intertwined with all of the other fights that we are fighting on the battleground of where voting restrictions are happening, where the anti-trans bills are happening, where the don't say gay bills are happening. All of these places where the intersection, I think, of all of these movements have a lot to do with what we as Black women know full and free, right? That we cannot be free unless we actually have bodily autonomy, unless we have the right to our own self-determination. And so it'd be really important for us to think about how do we link arms in movements and really drive these conversations together forward, because I think that's when we're most powerful.
Mm-hmm. Something that we've been wrestling with and reporting on and talking about in other areas of Capital B's coverage is trust in government institutions, health institutions, and how to rebuild trust when these institutions have failed Black people or have a racist history, or I mean, they all do. if they're old enough in America, they all do. Right. But we've really seen this really strongly in health with COVID. You wrote an op-ed last year about Planned Parenthood's complicated racial history, and it being time to really own Margaret Sanger's racial, not own it, but own up to Margaret Sanger, the Planned Parenthood's founders, racial views and racist beliefs. How do you navigate the complicated histories like this while trying to build trust with Black people, potential Black patients, when things are so important?
Yeah, I mean, look, to your point, like trust is everything, right? The currency of healthcare is trust, right? You have to have a relationship with your provider in order to to give them the information that they need, in order to give you the diagnosis that you need, in order to trust the information that they're going to give you back to treat whatever is ailing you. So that trust relationship, the bond between a provider and a patient is so critical. You can't get to better health outcomes for a community, much less an individual, if you do not have some basis of trust there. And I think the ways in which which racial bias show up, the ways in which discrimination implicitly and explicitly have shown up in our history is really clear, right? I mean, healthcare itself, the kinds of experiments that have gone on in our own community, right? The Tuskegee syphilis experiment was not a figment of our imagination. The lengths that the medical community has gone to dehumanize Black communities through experimentation and other ways of just denying us, you know, our basic dignity through care is real. And I think that it's important for us as a provider to differentiate ourselves from that. And whether that means to differentiate ourselves in our history, to acknowledge the fact that, you know, I don't know what was in Margaret Sanger's heart, but I know that there were things that she did that were incredibly troubling and racialized, and you know, and steeped in, you know, some very problematic work. And at the same time, I also know that just distancing ourselves from her and tying a little 100-year, you know, that was 100 years ago, bow around her and saying that was who she was then, and this is who we are now, is also not completely, you know, accurate, because we need to be able to prove that we've done the work to get here, right? The work isn't just about kind of moving forward a century. It's about what are we doing every day in our exam rooms? What are we doing every day in our health centers to ensure that that our patients experience a full set of belonging, that when we say, you know, you are seen, you are truly seen. We understand you, we understand what you are going through, we understand what you are asking for. And we're also talking, and I think this goes directly to the maternal health piece, you know, we're also talking directly about what it means to advocate for yourself in a healthcare system. Right. You know, because when we look at like the maternal mortality numbers, you know, yes, nationally, we are 3 times more likely to die than our white counterparts. But in some cities, it's like 9 times more. Right. And that is a function, you know, you look at those maternal mortality numbers, those maternal morbidity numbers, that's a lagging indicator. That means not only have you not been invested in terms of the kind of broad sexual and reproductive health care over the years, it also means that when you know something is happening with you, when you know that you are experiencing something, people are not taking you seriously in that moment. They're not seeing your pain in that moment. So what does it actually mean to advocate for yourself inside of your healthcare system, inside of your insurance system? I think those are the ways in which we demonstrate that we are differentiating ourselves from our founder, and, you know, and doing the work as an institution to say, this is how we want to show up in the community. And I can't think of anything more important in this moment, particularly as you mentioned, after the last 2 years of COVID, right? Where we also saw, you know, ourselves as, you know, essential bodies every day, getting on, you know, I'm in New York City, so getting on the A train, and yet seeing those same bodies not being able to advocate for themselves in the system, and that disconnect. So that's the work that I really wanted to point to in that op-ed, to make sure we were holding ourselves accountable.
You've been involved in leadership in Planned Parenthood for many years, but you became president in 2020, correct?
2019.
2019. Okay.
Oh, so, you're right. No, I'm sorry. I came in as interim. I can't remember my years anymore. I stepped in as interim in 2019. I became the full-time president in 2020, correct?
Yes. Okay. And, you know, that was a moment in time, a year when, you know, all sorts of industries, institutions, because of the George Floyd protests, were experiencing kind of a reckoning, where it was the moment to really examine deeply practices and traditions and all the different ways that these institutions and industries may have been operating in ways that perpetuated disparities. As a Black, you're the first Black woman, I think you're the second Black woman president of Planned Parenthood, but it's been a very long time since there was a Black woman president. What did it kind of feel like to take the mantle in that moment? I mean, I have to think that, you know, that Margaret Sanger op-ed was kind of part of it, like, you coming in and sort of having a really deep understanding of what the issues are across the board. But did you kind of have that, those thoughts in your head when you took the official president's role? And, how do you think that you're, performing the leadership of Planned Parenthood as you, with your identity and your history in maybe different ways than other leaders have been able to?
It's a great question. I don't often reflect on how I'm doing, but I will say what I have stopped asking myself for is permission to lead. There was a moment, the Margaret Sanger op-ed moment was a moment where, as an interim, I was really focused on just, healing the organization, making sure, like in kind of traditional Black girl fashion, right? Like a caretaking role, making sure everything was okay, tying the pieces together so I could hand it to the next leader. But there is something about becoming the permanent president and realizing that every institution, the CEO has a responsibility and an opportunity to make it their own in order to make it, to make it function and to make it work and to create your own legacy. And I think when I stopped asking for permission to lead and I just started showing up and saying, these are how will I make this organization the one that I want to belong to? Right? Not the one that I've been let steward for a while, not the one that I've been invited to, even sit at the table, but one where I actually truly feel like I am seen and I belong. And there is something very freeing in that, kind of claiming the mantle in a way, because no one ever just says, go ahead and go forth, right? You really do have to take it and say, this is who I am. This is how I'm going to model what freedom looks like. And every time I can do that, every time I can practice a sense of freedom in this role, I know it's giving freedom to my staff across the Federation to see themselves differently and show up differently, stop asking for permission to do the work that they know they need to do in order to make this the best organization for all people, but especially for our Black patients, our people of color, to ensure that they see themselves here, because we know when we do that work that we are actually building an institution for all people. So that's been like my guiding light. I'd be lying if I didn't say it was not a lonely job. It's a challenging job, but really building the kind of community and a very strong brown girl, Black girl magic community around me that I can share and exchange with, I think has also strengthened the work as well.
Mm-hmm. That's great. What are the sort of key areas of your work and Planned Parenthood's work that in your role you've really wanted to highlight, the specific way that this issue affects Black people? I mean, you Black women, you are you're the president of Planned Parenthood of America, not Planned Parenthood of Black America. But as we've talked about this whole conversation, there's so many ways in which Black women are more affected by some of what's going on. And what would you say are sort of some of those key issues where, like, you can't just say women or people who can get pregnant, like we're talking about Black women?
Yeah, I mean, look, I think this is where you have to, I'm a researcher by trade, so you have to start with the evidence, right? You have to start with what the data leads you. This is not about, yes, do I have a very strong identity around being a Black woman? Absolutely. That's how I was raised. That's how I will be raising my children. It is critically important for a number of reasons, but representation is not everything. We know that. It is about how do we look and understand who is being most impacted by, whether it's abortion restrictions, whether it's the experience of maternal health care, whether it's the experience of infant mortality, the higher STI rates. There are all kinds of ways in which our healthcare, our lack of access to healthcare, our lack of advocacy of ourselves inside of healthcare systems bias and discrimination inside of healthcare systems has created systems and structures and barriers, quite frankly, for us to have better health outcomes. So when I start by looking at the data, right, it takes you directly into a conversation around how to engage those barriers, how to transform those structures, how to have hard conversations, uncomfortable conversations that, you know, with providers to say, you know, this isn't about, you know, whether you, you have bias or not, right? Or you think you're a fair doctor or not. It's the fact that the data keeps showing us that these are the outcomes, and you're sitting at the intersection of the patient and the system. So we're going to have to figure out how we're going to work together and hold ourselves accountable around that. And so that's really where I see the kind of intersection of the work, and I think the ability to hone in very clearly and systematically around the experience of Black women in a way that when you center our experience actually helps create belonging for other communities, because we are literally building the skills and the competencies around what it means to see communities that have been rendered invisible for so long. And when we do that, we know it actually, you know, we're building the infrastructure that supports all communities.
Great. We have just a couple of minutes left. Do you have any final words on this topic? Anything that you think is particularly important for Capital B's audience to know or understand?
You know, I think that it's really about, you know, for me, talking about abortion access, talking about maternal care, talking about sexual and reproductive healthcare broadly, and including the span and the spectrum, is really important for us. That it is about, you know, at the end of the day, people frame this in choice. They frame this in decision making, and they make it about the individual and who has the right to make decisions about their own bodies. And I think that is the right frame. I think, but recognizing the fact that not everybody has equal access to choices, not everybody has equal access to information. And those are systemic choices, right? Those are the systems that impact our ability to make choices about ourselves. And so all of this work, as we fight for every person's right to make a decision about their own body, has to be tied with every person's and every system's right to create those fair choices, or those you know, that broad access to information and care, so that everybody can walk in and actually make a meaningful decision about their life. And you know, and I think that's where we sit at the intersection of any number of issues. And I think that's why it's so important that we stay, and that we kind of, as Black leaders, you know, continue to name access to sexual and reproductive care, to fight for access to abortion, to ensure that people are able to make these decisions in ways that are, you know, about themselves, their families, and their communities.
Great. Very well said. Thank you so much, Alexis, for joining us. I really appreciate it and appreciate your time in the conversation. Stay tuned for more from Capital B.
Thanks for having me.
Hi, I'm Jillian White, SVP of Revenue and Programming here at Capital B. We're so happy you joined us for this very important conversation. We'll be talking about solutions to Black maternal mortality risk. Joining me for this panel are Sona Smith, who works on birth justice for the Ms. Foundation, and Dr. Fleta Mask-Jackson, President and CEO of Majika, and leader and creator of Save 100 Babies. Thank you both for joining me.
Thank you for having me.
Yes, thank you.
So I want to start out, obviously, you know, we've been talking about maternal health today. That is such a sprawling topic when we think about maternal health care, reproductive rights, outcomes for babies. So I just want to ask each of you, what is the area that you are particularly focused on that you think is particularly important? So now I want to start with you.
Yeah, so right now I am the Birth Justice Program Officer for the Ms. Foundation for Women, and we currently are funding birth justice organizations and organizations who are doing community level strategies and grassroots movement building work to address disparities in birth experiences and birth outcomes. We're also addressing some of the funding disparities that we see, a lack of funding going towards organizations that are women of color led. And so we have a specific focus on funding organizations that are led by and that are serving primarily women of color, specifically Black and Indigenous women. Our organization currently has a request for proposals out for small grassroots organizations who are doing this work and who are seeking funding as well as capacity building support as well.
Yeah, so my work for many years now has focused on what are the effects of the stress and resilience based on racial and race and gender identity. And so, in other words, my work is focused on stress and the effects of racism and sexism on the birth and maternal outcomes of Black women. To that effect, that work has looked at specifically at how it affects mental health outcomes for Black women. So it does affect physical outcomes, but primarily I've looked at mental health outcomes. And so the work has also looked at what are the methodologies that should be employed so that you capture the authentic experiences of Black women as a way of measuring what are the risks they have and what are the things that they do to buttress those risks for them. So this work has certainly taken on a new kind of meaning in this pandemic era, where we are really focusing on mental health. And so the extra layer, what I call gendered racism, has particular significance as we look not only to document it, but to be able to assess and to measure it. So my work has gone from the qualitative to the quantitative, that it is an authentic representation of the lived experiences of Black women and what that means, both in terms of giving guidance in terms of how this is impacting the maternal as well as infant outcomes, but also give direction to what may be some of the interventions for addressing particular exposure. So that's primarily what my work has been about for these many years. And I've had the real great fortune and pleasure to work with people in the academy, thought leaders around what are the experiences of birth and pregnancy for Black women. I've had the opportunity to work with those who are in the provider space so that they are mindful and cognizant of what it is that the women bring when they come for their checkups, when they come for care. And I've had the opportunity to work in the policy space to see what things should be included so that it is resonant with what are the lived experiences and what is needed for us to move to birth equity.
That's amazing. So I want to talk a little bit about what are some of those mental health outcomes that we're seeing in particular for Black women, and then what are some of the interventions that you and folks working with you think would be most helpful?
So one of the effects of it is really depression. I can speak emphatically from my own research, from my own findings, that the stress of what we call gendered racism, which is the combination of the racism, but with a gender overlay on top of that, that it is a risk factor for depression or signs of depression. And so if you see signs of depression during pregnancy, it certainly has implications for other adverse outcomes, physiological birth outcomes, which can contribute to babies being born premature and ultimately can have an effect on women in terms of hypertension, diabetes, and those other things, which we know are clear risks for maternal morbidity and mortality. Furthermore, it is in this space that we begin to understand what are the factors that may be that are intervening, the intervention for those particular stressors. So I define and look at stress not just as exposures, but what are the resources that are employed when those exposures, when one has those exposures. And some in our own research, we are beginning to see what specifically friendships or social support like that can buttress that. or spirituality and or religiosity, if that's, and history and culture, because there are things that Black women bring in terms of what their lives are, what our heroes are, you know, who they represent, who we look to in our families as models, of, and who gives us that information and how they fit. Now, but we cannot look at it just as an individual intervention, because the big question is, what is the intervention against racism? That's a structural and systematic question, not an individual one. How we cope and deal with it is certainly that individual, but the burden of erasing racism and sexism cannot be on the shoulders of women themselves. But there are some intervening stages that we have to have. And so understanding this becomes critical in terms of reducing the adverse effects that we see on our pregnancy outcome. But they are, in fact, a reflection of what has happened. What we, in my work, we published a couple of years ago an article that looked at women's response to a question that said, they were asked, my children are more likely to have, my youth, Black youth are more likely to have adverse encounters with police than white children. And those who answered yes to that were more likely to show signs of depression, even if and these women were pregnant. So what it says is that even as our children are in the womb, we take that posture of having to protect them before they're born from the possibility of police violence. Well, there are two ways of addressing that. There's one in terms of the anxiety and what the mother herself must, in fact, be in a position where she does whatever she can to keep the worry down. But at the other hand, we have to reduce police violence too. They have to have those things happening at the same time and know that that is happening. So that's really been the nature of my work.
Yeah. Thank you so much for that, Dr. Jackson. Sona, go ahead.
Yeah, I want to echo everything that Dr. Jackson said, and also add that it's really important to think about community care and community health and a healing justice framework when we're thinking about birth justice and birth equity. For us, how we define birth justice is inclusive of that right to raise your children in safe and healthy communities. And so there are a lot of organizations that are embedded within the communities that have they have more access to the families, to the birthing people, to the children. And so I think one of those interventions that is needed is to definitely invest in the organizations that have taken the time to build those relationships, that are led by people who share identities with the people who are most impacted by birth injustice, that are responsive to the ongoing and the day-to-day needs of birthing people and their families, because those organizations are such a part. They bring that culture piece that Dr. Jackson talked about. A lot of times they have relationships with the healthcare systems, and these organizations look like a variety of ways. They can look like doula and birth worker collectives, but we see a lot of grassroots organization taking on this burden, right? We didn't create this issue, but we're taking on this burden to implement these programs and projects. And we're doing it a lot of times underfunded, right? There's a disinvestment in these types of organizations. They don't, they're not equipped with teams of grant writers and development teams. And so we see a lot of funding going towards birth equity and birth justice that are skipping over the organizations that are really at the root and on the ground. They have a hand that is deeply connected to the birthing people and their families, but then they also have hand in systems work and policy change work and advocacy strategies. And so I think one of the things that we can do to have an impact on the birth experiences and birth outcomes and mental health is supporting and building the infrastructure and capacity of grassroots organizations who are on the ground and really getting their hands dirty with meeting the needs of people who are experiencing mental health concerns or any types of issues connected to the wide spectrum of reproductive care.
So I want to follow up on that. It's a twofold question. And the first part might make you laugh a little bit, but the first part of the question is, why do you think we're seeing those funding gaps? And two, what can we do? What can our audience do as people who may be invested in these types of community solutions, who are certainly invested in bridging this maternal health gap that we're seeing? What can actually be done by folks who are listening to this, watching this, to be helpful?
Mm-hmm. Yeah, I think some of the gaps are an issue of just like capacity. I recently was an executive director of a really small organization here in Chicago, and I was the ED, I was the grant writer, I was human resources, I was finance, and I was directly supervising staff as well, and also still had some hands-on engagement with each of our programs and programmatic activities, which we see is the case with a lot of smaller organizations that are led by Black women and people of color. And so a lot of times it's capacity. And so ensuring that supporting organizations who have limited capacity, sometimes applying for a grant, it's a big lift, and that it can require hours and hours of time, of energy, of resources. You really need money to be able to raise money. And so I think a lot of the gaps are in capacity. But then I think also a lot of times philanthropy looks to some larger organizations that have more infrastructure and more support. You know, they have access to data, they have access to results, and they're presenting their impact in ways that funders understand. And a lot of times our grassroots organizations, they have the stories, they have the narratives, they have the personal connection, but I don't think we always see the same weight placed on that type of impact. And so I definitely think that the work that's being done is definitely fundable, is definitely impactful, it's expansive, it's innovative, it's creative, it's bringing in, you know, ancient and traditional and ancestral wisdom around birthing and birthing practices, but they don't have communications teams. You know, they don't have a media team. You know, the ED is also running the social media. And so whereas a larger organization may have a dedicated position to social media management and storytelling, an ED holding that role may be able to post once a week or once every other week. And so a lot of the work that's being done, those stories are not being told. And so I think for an organization like MIS, one of the things we do, we work to find those organizations and build relationships on the ground with the people who are doing the work, who hold identities that are really close to the identities of the people who are experiencing these negative outcomes and these disparities. And we pour into them, we build connectivity within a movement. So we're connecting organizations to other organizations, and we're also leveraging our relationships with other funders and philanthropists to tell this story. We recently released a report called Pocket Change, How Women of Color Do More with Less. And along with that report, we issued some fact sheets that give funders and other foundations a call to action to say, this is what the problem is, and this is how you can solve it. And so as I'm working to fund in the field, I'm also working on the philanthropic advocacy piece. And so when I'm in a room with funders, I'm telling these stories. I'm telling my story because not only am I now a program officer and working on the side of philanthropy, I also was the executive director of a small youth-led reproductive justice organization. And I also am a mom who has experienced birth injustice and obstetric violence, and has had to seek community support and community interventions to assist me with getting back on track. And so having panels like this, I think, helps. Having the conversation and also having people at the table like myself and like Dr. Jackson, and even like yourself, Jillian, you mentioned your personal story earlier with having a doula as well. Having people at the table who have been impacted on both a lived experience level as well as a professional level really helps.
Yeah. You know, I want to add to that because we certainly want to document what is taking place now, but we have stories to tell of what took place before. I was on a podcast earlier with Diane Raleigh, and Diane Raleigh was at CDC at the Division of Reproductive Health in the 1980s. And I shared with her what everybody doesn't know, the story of how we have come to the place that we're at now. So Diane Raleigh was someone who was early on in terms of why we have disparities in the 80s, and was part of research that showed that well-educated African-American women have worse birth outcomes than their white counterparts. And so was in a position that they could fund specific projects that would really respond to the questions, to that question of why. Why did not education and income, why was it protected for Black women as we expected? Well, I was one of those projects that was funded. Another project out in California, Healthy African-American Families, was funded. Another project in New York and Harlem was funded, all of which had a specific framework, a worldview around the authoritative voices of African-American women. And then I think about, and I'm still in existence, HALF is still in existence. The work that was done in Harlem has been foundational for those who are doing qualitative research. And then I look at the Ford Foundation and Virginia Davis Floyd, who was director of their reproductive portfolio, and Sister Song came for money, and Sister Song was funded. Well, Sister Song works with women of color around reproductive justice across the country. But one of the things that came out of Sister Song most recently has been Black Mamas Matter Alliance. Mm-hmm. Okay, and so 30 years, so sometimes we don't know how that funding has been the genesis of something that's bigger or waiting for a movement. And fortunately, I've seen this, I've had the opportunity to see the experience, so that there are people such as yourself and Jillian and others who now have the wherewithal, have a certain kind of understanding, can articulate a framework, but it also means you go back to the funders and that they understand that this is a long-term investment. And oftentimes they don't follow that investment. You know, I've said to people, I said, you know, Ford Foundation funded me and I'm still here. On a Sister Song, and it's still here. And now we have another generation of pioneers, of researchers, of policy wonks, of you name it, of providers who said, oh yeah, this works. They may not even understand what has been the path for. So it becomes very important for those who have the funding to recognize it and begin to be flexible and creative with the templates for funding, because that becomes another kind of barrier. Because if you have the organizations who, as you mentioned, you have to do everything. I figured out, I'm a small organization, but I am a very proponent of partners. So I partner with the public health, and they can take care of some of those infrastructure things. We work out what is the intellectual property, what they share, what we both share, and go forth. I figured that out for me. For other organizations, that's not possible. They need the full infrastructure to do it. So, but I'm in a good point now where we understand that as people are more entrepreneurial, as we have a lot ways of communicating that we didn't have 20 years ago. You know, that I can talk to you guys in Chicago and I can sit here in Atlanta, Georgia, and not have to, you know, not have to get a suitcase, get a hotel room, get all that stuff. So it is possible, and that's what makes it very exciting right now. And plus, their alignment with the legislation. I don't know what's going to happen with the Omnibus bill, which is comprehensive around Black maternal and all the maternal health, but it's written now. So pieces of it will now be pulled apart. The mental health piece, I think, will move forward because everybody's talking about mental health now. So, and I know those things will happen, but it's an exciting time. And as I listen to you as a funder, and I as someone who has done the research and work with others who are actually on the ground, who visit homes, and those who are doulas, and those who are community health workers. And so the emphasis on doulas has helped community health workers because it now recognizes that you need this level of support that is constant and well prepared, well trained, and able to maximize themselves and giving all the things that individuals need during their pregnancy.
Speaking of that, one of the questions I have for both of you, and this was something I thought about a lot during my first pregnancy, which was in 2020. So we're in the middle of a pandemic. Yes. We were stuck at home. Yes. George Floyd was murdered. And I remember I kept going into the doctor, and I work in news, and they would say, well, make sure you're managing your stress. And it was almost laughable. I was like, yeah. I remember I went to one appointment and DC was under a curfew that evening. And I was just thinking, how could I not be stressed out about all the things that are happening here and knowing that I'm carrying a Black child and thinking about their future? Yeah. I have no choice but to be stressed out. And then we had all of the articles and data that we were seeing come out for the year or two before talking about maternal health outcomes. So I knew inherently that, all of the privilege that I'm lucky enough to have, all of the education that I'm lucky enough to have, those things won't matter. Those things don't necessarily guarantee me any safety or anything else. So knowing how stressed out I was, and I was someone who was extremely armed with information, I had all of the information that one could want. I'm wondering if each of you can talk a little bit about if you were to talk to a Black woman who is expecting or a Black family who has just had a baby, what are kind of the number one resources or tools that you would recommend to them? So now I want to start with you.
Yeah, I would definitely recommend just like really honing in on the support system. I think Dr. Jackson mentioned this earlier about the importance of peer support, importance of community involvement. I think Black people, we are communal by nature. That is a cultural asset that we have, that we are, it takes a village. And I think that statement rings true, and especially is true through supporting the birth and the expansion and in all family planning options. So I think it's really important to encourage pregnant and birthing people to really figure out who their team is, and I do also understand that there are sometimes barriers within our own family structures, right, to having safe and supportive families. And like Dr. Jackson mentioned, with social media and with all of these virtual tools that we have now, I see a lot of virtual communities and virtual support that's happening. I'm seeing, breastfeeding groups and lactation support groups, and even I see some birthing partner support groups that local organizations are hosting, and mom and baby cafes. Because I think one of the greatest things is knowing that you are not alone, affirming and listening to the fears, to the stresses, and allowing them to face them and to lean into them, not ignoring them, not just saying manage your stress, because like you said, the circumstances are indeed stressful. I think naming those are important, naming those in community is important, and having a safe system and a system of care that's a safe space to land when those stresses come up. If you have an appointment and sometimes those appointments go so fast, you don't get a chance to ask all the questions that you had written down in your journal, because your provider is rushing you out because they have another person right behind you. But if you had a support system of other pregnant and birthing people who may be at the same stage as you. Like, you can bring those questions back to start to build that peer community and that peer support. And there are so many organizations that have community health workers, that have community doulas, that are doing this work and that have been doing this work for a really long time with very limited visibility. But I think because of the age we are in with social media access, these groups have Facebook pages, they have Instagram pages. There's been some creative TikTok videos that really help to you to be more confident in your self-advocacy, in your knowingness about what's happening with you, your body, your baby. And so I think community is key.
Thank you. Dr. Jackson, what's kind of the number one tip or resource or tool that you would want birthing people to be aware of?
I agree with everything that has been said. You know, you are in a space where you have access to so much information, maybe too much information. It can be, I read the other day about someone who took a month off of getting emails. Oh boy, I would be up the wall. But anyway, they did it, and they said, you know, they lived, you know, they survived, and I can't even imagine. And of course, and I'm pre-email, so you know, I lived a time where you had to wait or fax or whatever. But I think take some time for introspection, make some time for quiet time. Because with all the things that Sona has said, it is important for you to get still and get with yourself and your baby. You know, I can't even imagine, Jillian, when you were reporting and in the midst of that. I just, boy, I mean, you know, and I hope there was some times that you just took a breath because you knew all the things, that you took time. So I like those things, calm. I like those things like calm, that if you can take those for a minute, for how many minutes you have to recenter. You know, I think it's important that we have a recentering time because we are bombarded with so much stuff, you know, so much stuff, hours and hours upon hours of news. And, you know, I remember when Katrina happened and my husband forbade me from watching the TV. Sat there and I sat there and I sat there. So we have to be committed to taking some moments for inner journey. Then go forward with all of those other things, resources. I mean, you know, Black girl therapy and all of these things that are out here now that we didn't have before. You know, it was very hard for you to find a therapist, someone whom you thought related to what your experience was. There are many that are out there. The work of major organizations, March of Dimes, others who really do have these materials. They have reinvented themselves and packaged it in a certain kind of way, specifically for Black women, and to let you know, as we have seen as of late for the interrogation of Dr. Brown Jackson. Now the world sees what we've been saying, you know, and so how do we get through that? Is one thing. How do we get through the concerns for our children? How do we get through all the injustice in terms of pay and housing and what have you? And yes, there's a level of fight that has to happen with others because you can't carry that by yourself. You cannot. But to have a moment of peace and stillness before you can move on to the other thing. I've been reading a lot of writers and what they're saying about how they had the output, but you have input for you to with the output, and especially when you're carrying another life. You've got to have that time of quiet and still. And that's the kind of thing that a doula helps you to do. A doula should be able to help you to get still and quiet and focus on yourself and your and the growing human being in your body. So I would say have a posture, have a commitment to being still and quiet, and then move out to whatever else you have to do, and the supports that are available to you that were not available before. not in the way, but then some would argue that the family was more available then. And because we are so mobile in so many different places, that it's easy and not easy, because it's nothing like human touch.
Okay. You know, I could have this conversation absolutely all day, and I certainly wish I had had this conversation with both of you ahead of having my first child. Thank you so much for taking the time to share your knowledge, your journey, and your resources with our audience. I know this will be so invaluable to birthing people, to people with families, and to people who are just trying to support both families and this larger movement. So I just want to thank you both so much for joining us, and say thank you to our audience so much for joining us for this important conversation.
Thank you for having me.
Thank you.
Thank you so much for joining us for this important conversation about Black motherhood and the quest for joy in the face of so many of the difficult statistics and realities that we have heard about today. I am Simone Sebastian, editorial director of Capital B. I am also a new mother of a 12-month-old, fiercely opinionated baby girl. Joining me for this conversation are Helena Andrews, author and journalist for the Washington Post, and Leah Wright-Rigueur, author and historian at Johns Hopkins University. Leah, Helena, thanks so much for joining me.
It's a pleasure.
Thank you. I'm excited.
Yeah, thank you.
So I did not mention, and I should, Helena, you have two baby girls, 4 years old and 2 years old. Leah, you have three kids, a 9-year-old boy, 7-year-old girl, and a 20-month-old boy. So in addition to being mothers, you are professionals, have many hats that you wear. So I was wondering if you all could talk about what are some of the most surprisingly joyful things about motherhood that each of you have discovered during your own journeys. Helena, I'll start with you.
Wow. Okay. Surprisingly joyful. I would say, I mean, for me, I didn't come into my marriage. I didn't come into my womanhood thinking, oh, I want to be a mom. I can't wait to be a mom. You know, there are some folks who dream about having kids from the time they're kids, dream of wanting to be a mom. That was not me. I'm an only child of a single mother. Like, I like quiet in my house. Like, I just being a mom wasn't on my vision board. But then we had a baby and I was so excited. And I think the joy that came at the beginning was just in being pregnant and being on that new journey. I didn't expect it to be, you know what I mean? Because we as professional women, I think, especially as professional Black women, you're just on this grind. It's like checking it off the list. Okay, I did this. Okay, now I'm pregnant on this. And just being in my pregnant body in and of itself was a joyful experience for me, even though my pregnancies very much aligned with a lot of the renewed attention, the necessary attention that was being to the Black maternal morbidity rate, right? That was happening literally as I was baking a child. And yet I still was able just to find a lot of joy in my body. And thankfully, I had a very healthy pregnancy both times. But that was surprising for me. Like, I just enjoyed walking around and being this sort of like Beyonce, mother goddess being, and just really sitting in that. And that really helped me, I think, beyond that point. And then when the baby gets earthside and you're really in the thick of it, but starting in that space to where I could just really sit and enjoy, especially with the first pregnancy, the second, and Leah, I'm sure will speak to the third. Once another, small kid is around while you're walking around like a beach whale, it gets harder and harder. But I think that for me, just the very beginning and just sitting in that space and being like, wow, this is awesome. This is a big deal. And I should really sit and enjoy it. And that, I think, started me off on the journey really well.
That's great. I mean, I think your perspective there is particularly important because we do hear so much. I think a childless lifestyle is something that has become more acceptable for women, particularly Black women in this moment. And so I think it's especially interesting to hear a woman who did not plan that path find joy along that path. Leah, what was your experience?
Okay, so there are two things. I also want to echo a bit of what Helena said. So I love being pregnant. I know that's kind of an outlier, especially since pregnancy comes along with so many things that we don't talk about, like swollen ankles and, you know, like lightning strikes randomly in the middle of the day and all of that stuff. But I just really enjoyed the feeling of that. So I do want to echo that. But there were two really big things for me. I had heard a lot, especially going into my first pregnancy, about how scary and dangerous childbirth actually was. And that's true, particularly for Black women. But I have to say that I enjoyed the process of childbirth. I think it was a beautiful experience, but in this emotion is a little bit, I think, perhaps more distant from what most people are feeling. In addition to feeling joyous, it felt surreal. Like I went into the hospital one person and came out two, and I couldn't just discount the magic of that. And I've had two different kinds of childbirth experiences. I had one by epidural and then two without an epidural, and both had different kinds of magic. But I loved really both of them. Now, I may not have loved it in the moment. I may have been yelling. I may have been crying. I may have been like, okay, I don't, you know, this was a mistake. That's my favorite line to yell out. But the moment that, you know, someone's like, hey, your baby's here you go. That is, you know, I've written about this before. My reaction has always been laughter because it's such a it's a wonderful moment. It feels like a celebratory moment. And then the other thing that I think took a little bit of getting used to was, but that I love, that actually brings me so much joy, is the development of my children as individuals, like individuals with their own likes, their own personalities, their own independence. They're so different from one another, and they're so different from my husband and myself, that it has been just amazing to look at them and say, wow, you're like your own little you. You have likes, you have dislikes, you have, and there are things that are, I think, just bound up in them naturally. Like my 20-month-old, you know, does not like certain textures, and he will pull things out of his mouth and throw them. And I'm like, you're 20 months old and you already have an opinion about meat? Like that's pretty special. So nobody really told me about that, about how these personalities come out so quickly, but then go on their own. And I just feel very lucky to be entrusted with guiding them through the process of them discovering themselves. They're going to do it on their own, but I just feel really incredibly fortunate that I get to watch them through that process.
Absolutely. Okay, so Helena, I want to talk a little bit about your book, The Mamas. Was especially important for me as a new mom, and trying to, the new mom spaces are largely white, created for and by white women. And you were going through that process in the midst of America's racial reckoning. So I was hoping that you could talk a little bit about the differences that you saw in approaches to motherhood in that space, and what made your experience unique as a Black mom in that space.
Yeah, so The Mamas, my book, my motherhood memoir, reported memoir, comes out in August. And it was really, I started thinking about it when I had my first daughter in 2017. We live in Washington, D.C., in a very gentrified neighborhood. I am a joiner. I am not someone who thinks, and I actually learned this from friends of mine who had children and on their maternity leave felt very isolated because they also lived in these neighborhoods where, you know, when you walk down the street to the coffee shop, all the moms bogarting the tables don't look anything like you. So then you don't go out during your 6 months, hopefully 6 months that you have home. And it's so isolating. And I know people who literally developed, I think, postpartum depression around that fact, just being alone with this kid all the time. So I knew that I wanted to be in the stuff. Like I was like, oh no, we doing the baby yoga. We are going to the music class. Like I'm going to buy into all of this, going into it knowing that so many of the women, specifically in my neighborhood, because there are incredible, and I want to point that out, there are some incredible mothering support groups that have sprouted up around Black women, Black millennial women. In DC, we have District Motherhood, which is incredible. There's Mocha Moms, which has been around for 30 years almost, which is a national organization and actually started here in PG County. So there are those spaces, but for me, I needed easy access. Like if I have to go 30 minutes to get to a meeting, I ain't going. I need to roll out of the house and get to where I'm going. And so many of those women didn't look anything like me. And I knew that going in, and it was tough because going in, I had a guard up, right? Because there is, and I talk about it in my book, there is a distrust that for very historical and smart reasons Black women have when it comes to being vulnerable around white women. And you are never more vulnerable than when you have a new baby. Like literally, you are just like an open nerve all the time. You are worried, you are stressed, you are all those things, and you are joyful. It's just all of this is going on. So I think being really aware of that fact when I went into it. And one thing that I found, which for me was sort of a safe space in a weird way, especially as a new mom, is that there were no conversations when I had my first child in 2017, right? This is before our quote unquote national racial reckoning. I hate saying that, but we all know what I'm talking about when I do. And we never talked about race, right? It was just babies, baby this, baby that. What formula are you using? Are you not using formula? What is this? What is that? You know, what daycare? And that in a lot of ways was not comforting, but I felt I could hide out. Like I didn't have to think about race all the time, right? Because I was being told that I wouldn't make it through my daughter and I wouldn't make it out of the hospital, you know, that everything was dangerous. Like, so in that space, I was like, oh God, I get to like take this hat off for 30 minutes as we all sip coffee at the Ethiopian bodega. That was incredible. Then with my second daughter, it was completely different, right? And we were in this moment where it was like, suddenly these women waking up to the fact that like, oh, we are incredibly privileged. Like we are privileged in everything that we do. We're privileged in the things that we choose for our children, how we raise our children, how do we raise anti-racist babies? And then you're sitting there as the only Black mom in the circle, like, it's been like this, you know, you're like, welcome to the party, girl. And I would say at its most basic level, I was proud of a lot of these women to start these conversations, right? You don't want to do all the mental labor yourself. I'm not going to do all the work myself as the only Black mom in the group, but I still am hopeful that these women would even beg the question, right? And I talk about that a lot in my book. At one point, these moms in my group, they put together this like anti-racist baby board book, Excel spreadsheet, because that is what a certain type A DC woman does. Like, where are the books? Where are the resources? Where are the TED Talks? You know, and you laugh at it. But at the same time, I'm like, well, good, because they didn't ask me, thank goodness. You know what I mean? They weren't into my ear constantly about what they should do. They were proactive. And these are the children that they're raising that my children are going to be on the playground with. So I don't applaud that, because I don't applaud people for doing what they're supposed to do. But I'm glad they are doing it. And it was a really interesting, I think for me, a really interesting place to be, because I think across the board, you have a lot of these middle class, upper middle class Black families that exist. A lot of us exist in spaces where our kids could be the only one on their block sometimes. You know, they could be the only one at the playground. They could be the only one at the ballet class, depending on where you live. Thankfully in DC, I can curate her life to be pretty Black. But I'm hopeful, I will say, like in reporting out the book and just living this experience, I'm hopeful for the types of conversations a lot of these parents, not just moms, but these parents are having without being prompted by us. But it is different. It is a different experience. And I think the fact that we're recognizing that now is truly important.
That's great. Leah, let's also talk about your piece for The Atlantic, The Persistent Joy of Black Mothers. a really important piece that kind of looked historically at what Black motherhood was like and about. So one of the things that you wrote was a Black mother choosing joy is in stark contrast to the most prominent stories about Black motherhood. So hoping you could talk about some of the tropes and narratives that are out there about Black motherhood that you think have been harmful, and how do you see Black mothers kind of overcoming those and contradicting those?
Absolutely. So I think there's this long-standing belief that Black mothers are degenerate, right? That they're dangerous, that they're harmful. And, you know, it's not something even that is restricted to history. It's something that we see on display every single day. We see constant kind of interrogations, whether it be in the media or whether it be in, you know, kind of civic sources or things like that, about Black mothers and their children, or Black mothers having children taken away or being interrogated. I can think right now of the conversations that are swirling around Judge Jackson as she is confirmed for the Supreme Court, and her position as a mother that are being interrogated through a line of questioning that is, you know, asking about her fitness to be on the judicial bench, given certain, you know, things that she's ruled on, or sentences that she's handed down, right? All of that is wrapped up. And then also, there's another line that I think has emerged in part because of social justice activists who have done these kinds of pushing, that talks about Black women in relationship to their children, largely sons, that have been killed by the police. Mm-hmm. So, you know, the sociologist Jennifer Nash writes about how Black motherhood has now risen to the front of American society because of its proximity to crisis and to death. And then, of course, there's this kind of trope of the Black mother being a caretaker, right? So whether it be a wet nurse for white children, whether it be a domestic for white children, but it's always in proximity to others, not to her own children, right? So we take all of these things together, and a picture emerges that really pathologizes Black mothers. And one of the things that I noticed is that, one, this pathologization is in fact, classified by privilege, certainly, but also that in the Black mothers that I was interacting with, but also in the doulas, in the midwives that I spoke to, many of whom worked with working class and poor Black women, that the stories that we hear in the media were not matching up with the experiences of Black women on the ground. Right. So these tropes, these stereotypes, these narratives, in fact, are divorced from the actual experience of Black mothers, irrespective of their class, their status, or their privilege, right? Like poor Black women were finding joy in motherhood. Working class Black women were finding joy in motherhood. Middle class and wealthy Black women were finding joy in motherhood. And this was going on and on and on. And so I decided to write about it because I was really interested and invested in kind of unpacking these experiences. And one of the things that came out over and over again, actually, were two things. One, that there is no one narrative story, one monolithic story about Black motherhood. It doesn't exist. There are different versions of Black motherhood, but there is no kind of one thing that defines Black motherhood, with the exception of this next thing that I'm about to say, which is that, right, as I say, no, there's no one thing except this one thing, which is that Black mothers, over and over again, Black doulas, Black midwives, Black doctors, they all told me something that had a commonality, which is that they wanted choice. They wanted freedom. They wanted to be able to choose how they were going to experience their path in their relationship to motherhood. They wanted to choose in terms of reproductive freedom. They wanted to be able to choose what kind of mothers they were going to be. So choice becomes the point at which Black mothers, right, are united around Black motherhood. And it's something that has been missing from the conversation around Black motherhood. So even as we are talking about these stories about, the Black maternal health crisis, which are horrific, right? And this is in no way means to minimize them. But, to Helena's point, you begin to hear these stories over and over again in a way that anonymizes Black women. And you get told, well, you're not going to come out of the hospital, right? This is going to be a negative experience from you. you will most likely die in childbirth. Or if you don't die, you will have a horrible experience, right? And we hear this over and over again. And while the statistics might be true, and there's something that just deserve weight, there's a way in which Black women were divorced from that equation. So they became vessels for this larger crisis. And so we stopped listening to the actual stories of people on the ground. So I was particularly struck right before I had my son in 2020 by a series of stories that came out about Black women who died in childbirth. And almost all of the stories were about the crisis surrounding these Black women, but very rarely was anything mentioned about their names. We might hear their name as a one-off in a 3,000 long form article about this Black woman dying, but it's more about the repercussions in the institution and the woman herself. We don't hear anything about the lead up to this crisis. We don't hear anything about the woman. Was she happy? Did she choose this? Did she take maternity? You know, those corny but lovable maternity photos. Was she anticipating this birth? I wanted to hear more about the women themselves in these narratives, even the ones that had tragic outcomes. And so I wanted to start having these conversations, at least open up the door to having conversations about what choice meant for Black mothers and within Black motherhood, and placing aside the larger narrative about Black motherhood either being about, degeneracy or crisis or, negativism, but instead thinking about who these people were as individuals and what kind of agency that they had in relationship to their motherhood.
That's great. Really thoughtful thing. And it makes me wonder, how would you suggest for individual Black women, soon to be moms or soon to be second time moms, balancing these two sides of our kind of motherhood journey? There's an importance to understanding the additional risk that we have in the process of becoming mothers, the additional issues that we face that other moms don't, but also embracing the joy. I mean, how do we balance those two things as we, those two aspects of our motherhood as we approach it? Either one of you.
That is like the definition of being Black in America, right? We are constantly having to, have this double consciousness, be of two minds, exist in multiple spaces and spheres at once, knowing that it is dangerous to be in this Black body at any given time, right? But at the same time, I have to be me. I have to find joy. I have to enjoy this human experience. And I think it's the same, what makes it so much more fraught, obviously, when you are a mother, when you are pregnant, when you have a new baby, when you have a teenager, when you have one that's going off to college, is that you are responsible for this other piece of you that's walking outside of your body. So it is so fraught. But for me, I think what I'm trying to, and it's been a difficult journey for me most recently, as all of us, because on top of all this, we've been in a pandemic, right? And so parenting in and of itself has been just like a whoosh, just this hard experience in general. But for me, it's knowing all of that, right? Because I always know all of that, just like I know that, when my Black daughter goes into a school system, I need to be very aware of how she's being disciplined, how she's being spoke to. Like literally all of this is running in my head at one time, but she's also a 4-year-old, right? There's also just the magic that I constantly have to be attuned to and aware of, the magic that is just her as a child, which is incredible, and the magic that I want to create for her in her childhood, right? And to have her enjoy. And I think that that's something that Black mothers, as Leah was saying, it doesn't matter, across the economic, educational spectrum, whatever, are always doing that. It didn't matter. Like my grandmother raised 8 children. Christmas was always special. Easter, there was always an egg hunt in the back, right? There was, my uncle used to always pull up in a horse every now and then at the family reunion. Like there were always these magical moments for us as children, even as we were growing up in South Central Los Angeles, right? A dangerous place, but they made childhood special. And I'm constantly having to remind myself of that. Just this morning, I was rushing the girls to school, and I was late, and I was telling Sally, who's my oldest, and I was like, Sally, okay, we're in a rush. No joking around. I got to get you out of your car seat and into school. No joking around. And she looked at me. She was like, but I love jokes. And it was one of those moments where I just had to stop. And I was like, tell me a joke, babe. And she told me a joke that made zero sense. But it was her moment. And you constantly have to be aware of that. So as I'm running all the mom stuff in my head, we're late, got to get her into school, got to make sure her COVID test is in, all those things. But I have to stop for the magic that is this little girl's childhood, because she is a full person, right? I'm trying to make her aware of the fact she knows very much that she is a Black woman. She knows very much what it as is appropriate, what it means. But at the same time, like, you are just this ball of opportunity and all of those things. And I just want to make sure I'm pouring into that as much as I can, as well as keeping all the other stuff in my head. But I think for Black folks, right, that's how we operate. We will operate on that wavelength all of the time. And sometimes I think we can, skew one way, the pendulum can swing this way as opposed to that. And as long as some days it will be here, but some days it'll be over here. And you just have to give yourself grace.
I think that's great. I'm finding those moments of magic in all of the chaos and difficulty. And the little ones definitely help with that once they're here, for sure. One place and you mentioned this a little bit earlier, Helena, spaces for Black moms seem to be becoming more numerous, which is great. For me, it was Mocha Single Moms by Choice. You wrote about the Mom Friends. So I just wanted to give a shout out to some of those. If there are Black mom spaces that you guys know of and you think are really effective, what makes them effective? And what are the ones that kind of stand out for you all?
Yeah, so I think there are a lot of actually Black mom spaces, particularly that have emerged in the last 5 or so some odd years. But I also think about like the really old and to some extent, sometimes curated Black mom spaces. So certainly there's Mocha Moms, but there's also Jack and Jill, which has historically been a Black moms organization for their children. But then also I was pretty impressed by the number of doulas and midwives that I spoke to who have created postpartum spaces for Black moms, particularly low income or working class Black moms. And the idea is that they take, the doulas and the midwives provide the space to take the pressure off of the Black mothers. And in doing that, they feel like they are giving them freedom. They are giving them choice, far more choice than they would have under different conditions. And I thought that was pretty profound, because we tend to focus on, the part where we're pregnant. Like all of the attention goes up until you have, the baby. So prenatal care. But we actually don't think about the postnatal space and how important that is, not simply for, figuring out how to live life as a baby, but figuring out how to live life as a mother, like how to even survive. And so I think seeing those crop up, particularly under the pandemic, is pretty important. And I would actually love to see more of those kinds of spaces, because I think they do just a really good job and a desperately needed service for women in our community.
And I would add, and Simone, you mentioned there's District Motherhood, which puts on the Mom Friends, but they also do, stroller walks in the park. They do boobies in the park where, they just go and everybody breastfeeds, and which is an act of resistance and joy for Black women, right? There are all of these local sort of events that they put on. They do the Mommies in Blanc in August, where it's just like all these Black mothers and their children show up in all white to a park and just have a big picnic. Again, just this incredibly joyful moment that folks can participate in. And then beyond that, obviously we mentioned Mocha Moms, but for me, in terms of all that too, and I talk about it in our book, I would do all the things because I'm a joiner. I like to be around people. I feed off the energy of people. One thing that also helped us in just our neighborhood, as it was changing, right? We knew some people, we knew other Black parents here, and we just got real bold about, oh, Black woman with a baby, I see you across the street, let me cross the street. Hey, how are you? My name is Helena, our kid, you know, like really like curating those moments that I knew, okay, we should know each other, right? Our kids should know each other. And in this day and age, and it's been really tough, obviously coming out of the pandemic, doing that, right? You didn't go up to people you didn't know, like we weren't trying to meet in person for certain things, but we have been, I think as a group in the neighborhood that I live in, and as well as just like DC in general, is just reaching out and seeing someone and saying like, hey, I know you are probably on the struggle bus with me too. Like, let's ride this together. Let's meet up. Let's go to coffee. Let's be outside. Let's be safe. All of those things. And folks being much more open to that now, I think, than they were even pre-COVID, because they realize how important human interaction is and shared experience. And I would just, again, to any new mom listening, the mom with, 5 kids listening, those spaces exist, like they are there, and they've been there for a while, as Leah was mentioning, but so many are cropping up. There's Matter Mia online, which highlights Black mothers, highlights Black parenting. There are so, because I think a light has been shed on Black motherhood and Black maternal morbidity, there's that, but also just Black parenting and Black family in general. If we talk about the pathology and the images that we've seen since the Obamas, right? Since Michelle Obama walked into the White House as mom in chief, right? And as Black women, that was a moment. And I remember the debate white feminists were having about like, oh, why would she say she was the mom in chief when she's so accomplished? And we were like, because that's huge. Like, that is her standing in that title as mom, and only having to focus there in the national spotlight, that made so much sense. And I think that we've been in sort of this like mama-sance ever since there, especially when it comes to Black women. So there are so many resources out there, and I think there's a lot of power in numbers, and we're seeing that now.
These kinds of conversations, creating spaces to have these kinds of conversations that both understand the unique positioning of Black mothers and Black women, while also celebrating just the truth of Black motherhood, right? It's complicated, but it's also rich. And, Toni Morrison says that Black motherhood, in fact, can be one of the most freeing and celebratory things that we can experience. So creating a space to actually talk about that in the midst of both a health crisis, a Black maternal health crisis, a crisis of race and policing that disproportionately affects Black mothers and their children, that's powerful, and it's also important, and it's necessary.
Excellent point. Excellent point to end on. So thank you guys so much again, and appreciate your joining us for this.
Thank you.
Thank you.
Thank you so much for joining us today for these important conversations about Black women and health equity. A special thank you to all of our guests for sharing their time, stories, and expertise with our audience. As always, you can keep up with Capital B by becoming a member and signing up for our newsletter and emails. You can also scan the QR code that will appear at the conclusion of this event. And don't forget to follow us on social media at Capital B News. A full replay of this event will be available on Capital B's YouTube channel. We hope to see you next time. Thank you.